involvement with its IMA headquarters End TB Initiative Standing Committee under the able leadership of our past National President, Dr. R.V. Ashokan. We have tied up with the National Tuberculosis Association in this regard, and we are committed for a rapid implementation of WHO guidelines and policies to strengthen these national strategies. As part of this initiative, we have arranged this webinar with eminent speakers of Karnataka. We have done lots of hard work to curtail this evil disease. We'll move ahead with, I request Dr. Surya Raju, our state IMA Honorary Secretary, to go ahead with the program.
ಎಲ್ಲರಿಗೂ ಈ ಕಾರ್ಯಕ್ರಮಕ್ಕೆ ಸುಸ್ವಾಗತ. ಮೊದಲನೇದಾಗಿ ಭಾರತೀಯ ವೈದ್ಯಕೀಯ ಸಂಘದ ಪ್ರಾರ್ಥನೆ, ಎಲ್ಲರೂ ಸಂತೋಷವಾಗಿರಲಿ, ಎಲ್ಲರೂ ಆರೋಗ್ಯವಾಗಿರಲಿ, ಎಲ್ಲರೂ ನೋವಿನಿಂದ ಮುಕ್ತವಾಗಿರಲಿ, ಎಲ್ಲರೂ ದುಃಖದಿಂದ ಮುಕ್ತವಾಗಿರಲಿ, ಎಲ್ಲ ಆಸೆ ಆಮಿಷಗಳನ್ನು ಮೀರಿ ಗುಣಪಡಿಸುವವರು ನಾವಾಗಿರಲಿ. ಧ್ವಜವಂದನೆ. ಭಾರತೀಯ ವೈದ್ಯಕೀಯ ಸಂಘದ ಸದಸ್ಯರಾದ ನಾವು ನಮ್ಮ ರಾಷ್ಟ್ರ ಧ್ವಜಕ್ಕೆ ವಂದನೆ ಸಲ್ಲಿಸಲು ಇಲ್ಲಿ ನಿಂತಿದ್ದೇವೆ. ಅದರ ಗೌರವ ಮತ್ತು ವೈಭವವೇ ನಮ್ಮ ಬೆಳಕು ಮತ್ತು ಶಕ್ತಿ, ಮತ್ತು ಅದರ ಪಥವೇ ನಮ್ಮ ಪಥವು. ಈ ರಾಷ್ಟ್ರೀಯ ಸಂಸ್ಥೆಯ ಮಾನ್ಯತೆ ಪಡೆದ ಸದಸ್ಯರಾದ ನಾವು ನಮ್ಮ ಜವಾಬ್ದಾರಿಗಳನ್ನು ಅರಿಯುವ ಮೂಲಕ ಅದಕ್ಕೆ ನಮ್ಮ ನಿಷ್ಠೆಯನ್ನು ತೋರಿಸುವ ಪ್ರತಿಜ್ಞೆ ಮಾಡುತ್ತಿದ್ದೇವೆ. ದೇಶ ಸಮೂಹಗಳ ನಡುವೆ ನಮ್ಮ ರಾಷ್ಟ್ರ ಧ್ವಜವು ಉನ್ನತ ಮಟ್ಟದಲ್ಲಿ ಹಾರಾಡುವ ಸಲುವಾಗಿ ನಮ್ಮ ಅಧಿಕಾರದಲ್ಲಿರುವ ಎಲ್ಲವನ್ನೂ ಅದಕ್ಕೆ ಸಮರ್ಪಿಸುವ ಪ್ರಮಾಣ ಮಾಡುತ್ತಿದ್ದೇವೆ. ಜೈ ಹಿಂದ್. IMA ಚಿರಾಯವಾಗಿರಲಿ. ವಂದನೆಗಳು.
Yeah, thank you, sir. And I request our IMA Karnataka State Branch State President, Dr. V.V. Chinavala, to have his initial words. Sir, kindly unmute.
Sir, kindly unmute.
We can hear you. Yes, sir.
ಎಲ್ಲರಿಗೂ ನಮಸ್ಕಾರ. ಹೊಸ ವರ್ಷದ ಉಗಾದಿಯ ಶುಭಾಶಯಗಳು ಎಲ್ಲರಿಗೂ. ವಿಶ್ವ ಕ್ಷಯರೋಗ ದಿನಾಚರಣೆ ಅಂಗವಾಗಿ ಪ್ರತಿ ವರ್ಷ 24 ಮಾರ್ಚ್ ಕ್ಷಯರೋಗ ದಿನಾಚರಣೆಯನ್ನು ನಾವು ಆಚರಿಸ್ತಾ ಇದ್ದೀವಿ. ಈ ಕ್ಷಯರೋಗ ಈಗ ಕೇವಲ ಇತ್ತೀಚೆಗೆ ಅಲ್ಲ, ಕನಿಷ್ಠ ಇದು 3 ರಿಂದ 4 ವರ್ಷಗಳ ಹಿಂದಿನಿಂದನೂ ಇದು ಬಂದಿದೆ. ಸೊ ಈ ಒಂದು ಕ್ಷಯರೋಗ ರಾಬರ್ಟ್ ಕಾಕ್ ಅಂತ ಹೇಳಿ ಏನಂತಲ್ಲ, ಇವರು ಇದನ್ನ ಯಾವ ರೋಗಾಣುವಿಂದ ಕಂಡುಹಿಡಿದ್ರು, ಅದಕ್ಕೆ ತಕ್ಕಂಥ ಅಲ್ಲಿಂದ ಇಲ್ಲಿಯವರೆಗೂ ಸಹ ಏನಂತಲ್ಲ ಸಾಕಷ್ಟು ಆವಿಷ್ಕಾರಗಳು ಆಗಿ ನಾನಾ ಥರದ ಔಷಧಿಗಳು ಸತಿಗೆ ಲಭ್ಯವಿದ್ದು. ಆದರೆ ಈ ಒಂದು ಸಂದರ್ಭದಲ್ಲಿ ನನಗೆ ನೆನಪಾಗ್ತಿರೋದಂದ್ರೆ, ನಮ್ಮ ಭಾರತದ ಪ್ರಥಮ ಮಹಿಳಾ ವೈದ್ಯೆ ಡಾಕ್ಟರ್ ಆನಂದಿ ಗೋಪಾಲ್ ಜೋಶಿ ಅವರು ಏನಂತಲ್ಲ USA ಹೋಗಿ MD ಡಿಗ್ರಿ ಪಡೆದುಕೊಂಡು ವಾಪಸ್ ನಮ್ಮ ದೇಶಕ್ಕೆ ಬಂದು ಸೇವೆ ಸಲ್ಲಿಸ್ತಾ ಇದೆ. ಆದರೆ ದುರದೃಷ್ಟವಶಾತ್ ಆ ಹೆಣ್ಣುಮಗಳು USA ಹೋದಾಗನೇ ಈ ಟ್ಯೂಬರ್ಕ್ಲೋಸಿಸ್ ಅವಳಿಗೆ ಅಂಟಿಕೊಂಡು ಬಂದು ಇಲ್ಲೇ ಕೇವಲ ತನ್ನ 21ನೇ ವಯಸ್ಸಿನಲ್ಲಿಯೇ ಆಯಮ್ಮ ಏನಂತಲ್ಲ ತನ್ನ ಕೊನೆಯ ಹೆಸರು ಹೇಳಿದ್ಲು. ಸೊ 1865ನೇ ಇಸ್ವಿ ಇದು. ಸೊ ಆಗ್ಲಿಂದ ಈಗಿನ ನೂರಾರು ವರ್ಷಗಳು ಕಳೆದ್ರೂ ಸಹ ನಾವು ಇನ್ನೂ ಏನಂತಲ್ಲ ಟ್ಯೂಬರ್ಕ್ಲೋಸಿಸ್ಗೆ ಸಾಕಷ್ಟು ಟೆಕ್ನಾಲಜಿಗಳು, ಸಾಕಷ್ಟು ಔಷಧಿಗಳು ಎಲ್ಲವೂ ಬಂದರೂ ಸಹ ಇನ್ನೂ ಅದನ್ನು ನಾವು ಪೂರ್ಣ ಮುಕ್ತಗೊಳಿಸಲು ಅದಕ್ಕೆ ಈ ಸಲ ನಮ್ಮ ಪ್ರಧಾನಮಂತ್ರಿಗಳು ಏನಂತಲ್ಲ ಟ್ಯೂಬರ್ಕ್ಲೋಸಿಸ್ ಅಂತ ಹೇಳಿ ಇತ್ತು, ನಮ್ಮ ಭಾರತದಿಂದ ಮುಕ್ತ ಮಾಡಿಸ್ಬೇಕು ಅಂತ ಹೇಳಿ ಒಂದು ಧ್ಯೇಯ ವಾಕ್ಯದೊಂದಿಗೆ ಮಾಡಿದ್ದಾರೆ. ಇದಕ್ಕೆಲ್ಲರೂ ಸಹಕರಿಸಿ ಏನಂತಲ್ಲ ಈ ಒಂದು ಟ್ಯೂಬರ್ಕ್ಲೋಸಿಸ್ನ ನಮ್ಮ ದೇಶದಿಂದ, ನಮ್ಮ ರಾಜ್ಯದಿಂದ ಎಲ್ಲ ಕಡೆಯಿಂದನೂ ಮುಕ್ತಗೊಳಿಸಲು ಎಲ್ಲರೂ ಸಹಕರಿಸೋಣ ಅಂತ ಹೇಳಿ ನನ್ನ 2 ಮಾತು ಮುಗಿಸ್ತೇನೆ.
Thank you very much, sir. We shall go ahead with the webinar. I request Dr. Anil sir to come. Sir, are you there?
Yeah.
Yeah, I'll share your PPT, sir.
Thank you.
Yeah, 1 second.
Yeah.
Sir, your video?
No, if I put my video, I think the network will go slow. That's why.
Yes, sir, no issues.
Sir, the introduction of Dr. Anil.
Yeah, I'll do it. Wait, madam. John, can you see?
Yes, sir.
Yeah, screen ಕಾಣುತ್ತಲ್ಲ?
Yes, sir.
Yeah, it's my privilege to introduce Dr. Anil. Yes, presently he is working as Deputy Director of Tuberculosis of our Karnataka state and is also Director of STDC and also in charge Joint Director of Lady Wellington State TB Center, Bengaluru. He is an alumni of Mysore Medical College, got his fellowship in advances and research in management of diabetes, and also he is trained in endoscopy, and he is also trained in comprehensive course in multi-drug resistant tuberculosis. And he has got 26 years of service in various capacities at the Health and Family Welfare Department, Government of Karnataka. He is honored with Pulse Polio Immunization Best Service Award, Rotary Bangalore Brigades Award for Best Services in Pulse Polio, Best Deputy Director Award for World TB Day on 2012. He specializes is especially special interest management of drug-resistant tuberculosis, TB, and HIV, and etc. He has 18 publications to his credit. Here is Dr. Anil S. and IMA Karnataka State Branch welcomes you, sir. We want to hear you from.
Thank you so much. Thanks everyone for joining, and it's a privilege to be associated with IMA always. So I'll be just going through a short presentation on only the updates, whatever we have in the last 1.5 years on the TB program, which is absorbed by the National TB program. So the bigger form of the presentation will be done by Dr. Nirmala and Dr. Hamza. So the first change that what we have seen is the screening component. So initially, we were doing screening with what is called as 4S, 4 symptom complex. It used to contain fever, cough for more than 2 weeks, weight loss, night sweats. Chest pain was added along with hemoptysis. So, but 4S carried only the 4 symptoms. Now we have added 10 symptom complex, which contains all those what you are seeing: shortness of breath, weight loss, loss of appetite, swelling in the neck, other extra pulmonary symptom. The one thing that I have put in bold is abnormal chest X-ray. So goes to show that X-ray has a value as a screening tool and not as a testing tool. That's the first point that I want to drive. So, if for all the doctors here, along with the 4 symptom complex, chest X-ray in TB is a screening tool and can is not the diagnostic tool for TB. So we and here another thing that is very characteristic of the chest X-ray is abnormal chest X-ray. We are not using the word chest X-ray suggestive of TB. We have just used abnormal chest X-ray. Even if you know that this patient is a COPD, you know he has bronchial asthma, you know he has ILD, you still, if you find this kind of a shadow for the first time, it is always wise that we rule out TB in this patient, and the test offered would be NAT. Next slide, please.
Yeah, I'll.
Yeah.
Yes, sir.
The second very important change that came this year, which was there lingering for around 2 years, was the new drug resistant TB regimen called the BPAL regimen. So in India, it is modified as BPAL M regimen. Dr. Hamza would be speaking more on this. I'll just take you to through the journey of drug resistant TB. I hope most of you know the journey of drug resistant TB. If you look at how drug resistant TB was initially diagnosed, it was an LJ media, which would take 8 to 12 weeks for the diagnosis of drug resistant TB. And by the time the results would come, 30% of the patient would have died waiting for a DST report. So then came the liquid culture, then came the line probe assays, then came the NAT. And today we are speaking of next gen sequencing for looking at various putative genes that determine drug resistance. So a journey which started from 8 to 12 weeks has come down to now with NAT 2 hours. With first line and second line NAT, it would be 4 hours. So what was 12 weeks has come down to 4 to 6 hours. Or in Karnataka, we have stringent turnaround time with LPA less than 3 days. We will give first line and second line LPA. And these are all genotypic tests. The phenotypic test takes its own time because we have to grow the TB bacilli. So that uh, is the hitch in whenever you offer a uh, phenotypic test. So the BPA, when it comes to patient management, if you know the characteristic of TB, drug resistant or MDR TB management, initially it was 24 to 27 months of treatment with 6 to 12 months of daily injectables of aminoglycosides, that too intramuscular. 20 to 40% would have ototoxicity or nephrotoxicity. And currently we have a fixed standardized regimen, non-injectable regimen. So we don't use injections at all. So our regimens are now like BPAL, which is 6 months. Uh, we have the all oral longer regimen, which is around 18 to 20 months. And we have the shorter bedaquiline containing regimen and the INH monoresistant TB regimen, which is also around 9 to 11 months. So the BPAL regimen contains the new drug called predominant, the other three being Reaper bedaquiline, linozolid, and moxifloxacin. So these are all our TB drugs are standardized in nature, unless otherwise. These are all standardized regimens. You put the medication or you take out the medication. Only the regimen that is, what can I say, patient centric or based on DST guided regimen will be all oral longer regimen. Next slide, please. So as the slide moves, one very important aspect of TB program is we are going one step back to manage TB. So previously, latent TB was considered as a different entity. Now it is considered as a cascade of TB disease. So you start with the TB infection, then first is exposure, then is infection, then it is TB disease, and the natural history of the disease continues. So TB infection management, which was very limited, is now the front page of TB control program. So we are uh, having three tests now for diagnosis of or ascertaining TB infection. One is the interferon gamma release assays IGRAS, the age-old tuberculin skin test, and now the newer one, CYTB. So we have all the three things available with us. We have IGRAS with us, we have CYTB with us. TST is not available. In a country like ours where TB burden is huge, we'll have to use 2 TU or 5 TU. And one sincere request to all my friends here is with respect to TST MAN2. So I have seen when I go to the field that somebody takes out a 10 TU and then dilutes it and say, divide it into two parts and say each one is 5 TU. No, you'll have to use only 5 TU only. You can't take 10 TU, convert it into 5 TU. That does not happen. So IGRAs are good. Uh, both are hypersensitivity reactions looking at ISAT6 and CFP10. Dr. Nirmala will be covering more on this. And it has, next slide, sir. We'll look at the vulnerable groups. So these are the vulnerable groups or target population to whom we are doing. So initially we started with kids less than 6 years of age who are in contact with pulmonary TB patients. Then for HIV, all those who are HIV infected after ruling out active TB disease. And then we started with contacts of pulmonary TB patient household. And then we are now slowly expanding the TPT network to other groups like people with ESRD, undernourished, diabetics, people who are silicosis, waiting for organ transplants, who are on TNF alpha antagonists. So the gamut of people being treated with TB preventive therapy is becoming bigger and bigger. The only thing that I want to tell all my friends here is whenever we initiate somebody on TB preventive therapy, the one and only thing that we'll have to do is to rule out active TB. So, no, because we are using a single drug or a two drug for managing TB preventive therapy. So, it is always necessary, quintessential for us to rule out active TB. Once you have ruled out active TB, then you can initiate the people on TB preventive therapy. Uh, Mind us that these are all not TB patients. They are just infected with TB. The lifetime risk of somebody getting TB is just 10% in normal individuals. But with HIV, it is 10% here. It is 25% more than the normal individuals in household contacts and similarly in other groups. Next slide, sir. So these are the regimens that are available in India. WHO has much more regimens. They have 6H, 9H regimens. But in India, we have 6H, that is 6 months of INH, which is given as 5 milligrams per kg body weight in adults, 10 milligrams as kg body weight in children. We have 3 HP, weekly doses of INH and rifampicin. Large doses of INH, 900 mg of INH, 900 mg of rifampicin given once a week for 12 weeks. Then we have 4R, that is rifampicin, given once a day for 4 months for those who have INH resistant TB and sensitive to rifampicin. The household contacts are given this, and 6 months of levofloxacin who have rifampicin. The people who are in contact with rifampicin resistant TB, but they're sensitive to quinolones, are offered 6 months of levofloxacin. And a special group, PLHIV, they are offered 6H or 1 HP. What you see as 3 HP, we lower the dose in these people, 300 mg of rifampicin and 300 mg of INH daily for 30 days. What does it do? Is what I want to just 2 points. The protection rate of TB preventive therapy to cover the patients in, or, in order to prevent the person getting TB disease is as high as 60 to 90%. And for sure, it is more than 85% in HIV group. So TB preventive therapy, when given, it is given only once now. The protection is for 3 to 5 years. There are some European and African countries which are giving a TB preventive therapy for more than once. But in India, the current guideline says that it is given only once, and the protection is very well documented in age group less than 5 and in the group of HIV people. So this will drastically bring down the incident TB. ಈಗ ನಾವೇನ್ ಮಾತಾಡ್ತಾ ಇದ್ದೀವಿ ಕ್ಷಯಮುಕ್ತ ಭಾರತ ಕ್ಷಯಮುಕ್ತ ಕರ್ನಾಟಕ, if the coverage of TB preventive therapy swells to around 80%, then in the next 3 years, we'll be seeing a drastic fall in incident TB. Next slide, please. So, one thing that I wanted to discuss about TB preventive therapy before I go to inpatient screening is TB preventive therapy is done in two ways. It is either test and treat or screen and treat. Just because somebody does not have IGRA or TST or CYTB, it doesn't mean that the contacts should not be uh, provided with TB preventive therapy. All we have to do is to look at the TB symptoms. If they don't have TB symptoms, then do a chest X-ray. Chest X-ray is normal. Then he can be initiated on TB preventive therapy. This strategy is called a screen and treat strategy. The next one is the test and treat, where we offer IGRA or CYTB, and based on the results, we treat the person. And the next very important activity that Karnataka has started is called as the inpatient screening. This is a easy way of doing getting TB numbers, irrespective of what the patient is admitted. He would have come to you with DKA, he would have come to you for cataract surgery, he would have come to you for urinary incontinence. The staff nurse will be asking very simple questions, that whether the person is having cough, weight loss, fever in the past few weeks. If the patient says yes, then he is offered chest X-ray, and then if there is any abnormality, he is offered NAT. These are all for inpatients. They are there within the system, and this year, last year when we did, we got 2,900 patients in Karnataka who had come to the hospital not for TB but for other reasons, and TB was an incidental diagnosis in this. Goes to show that if we do this very diligently in across, all the we did it in all major hospitals, but wherever inpatient care is there, if this is done, then we can have much more TB patients, and then early diagnosis is possible with better outcomes. So this is one strategy we are doing. Other one is called as steps. Next slide, sir. Yeah. Steps. It is system for TB elimination in private sector. So we have established more than 1,200 step center. The people in the private hospitals are trained, they are given Nikshay logins. They are given drugs. Drugs are kept, and patients are managed by themselves. They need people, they need not refer patients to public health facility for management. So the diagnosis is done free of cost for them. We link them up to a CBNAT site. So they will only collect the sample. They will only drop the sample. We will do the CBNet, we will give them the result, they will only manage, they will only do the Nikshay. So everything is done by the system. So we have around 1,200 hospitals doing this in Karnataka. So next slide, sir. I think there are just a couple of slides from my side. The one activity that we are doing currently is called as this is called Nikshay Divas, wherein wherein all the TB patients in the community go to the nearest PHC for evaluation. It's a sort of reassurance for TB patients. This is happening more in the rural areas, where patients are assessed for weight gain, mitigating the comorbidities or control of comorbidities, reassurance to the patient. All these things are done along with follow-up. So clinical and laboratory follow-ups are done. So this is one activity that we are doing. And the next is called as the TB Mukt Gram Panchayat. So today we have around 1,060 Gram Panchayats declared as TB-free Gram Panchayats this year, are certified. So we started with initially we thought of taking it as TB-free sub-center, but then we wanted some political and administrative commitment. So the grassroots level, we have the Gram Panchayats. Gram Panchayats, few of the Gram Panchayats have taken it quite seriously. They do participate in TB-free activities. They support the ASHAs, community health officers. They they are they provide us with IEC materials. They do help us. And once this certification is now done at the district level by the CEO and DCs. So I think this will catch up in the next year, where those Gram Panchayats that they are not certified, will also take this and do it. So this is what we have done. The other one is the Pradhan Mantri TB Mukt Bharat Abhiyan. This is a very novel way of supporting TB patients. It is an additional nutritional support given to consented TB patients by an individual or a corporate. So it costs around 600 to 800 rupees per month per patient. So if an individual pledges that he is going to support a TB patient, it will be for a period of 6 months. He will be supporting. As on today, we have more than 5,000 donors who have supported with more than 1 lakh nutrition kits. So other than that, we have bigger corporates who have supported the TB program by providing handheld X-rays, uh, by providing CBNet machines, TrueNet machines, vocational support to TB patients. Most of you know that there is so much of stigma associated with TB. So we'll have to break that also. We'll have to do early diagnosis, a lot of counseling. So the helplessness in the patient, there will be some kind of a dent on the mental well-being of the patient with TB. So that is taken care of Pradhan Mantri TB Mukt Bharat Abhiyan. Next slide, sir. So another thing that we have is the TB Arogya Sati, where a patient can download this app by himself on an Android. And if there are any questions that are associated that he wants to ask, he can monitor his own other ends. He can ask questions. He can raise complaints. Say if there is no drugs, so or drugs are not reaching in time, he can raise complaints on TB Arogya Sati. That is another thing that we have with us. Next slide, sir. Apart from this, we are now looking at unveiling the chatbot in Canada. This chatbot will have around 3,500 questions. I've already told you patients will have a lot of questions in their mind. And as doctors, we don't find time to answer those questions. So if you ask these people to download this on their Android, there are 3,000 questions that are answered in the most appropriate way. So they can ask questions onto themselves and they can take answers. It's a voice questions can be asked. It comes as both voice as well as in writing. So this is another thing that Karnataka will be doing in the next few months. So this is in brief on the update because Dr. Nirmala would be expanding on what I have told on a clinical terms, and Dr. Hamsa will be doing. Once again, thank you so much for giving me an opportunity. Uh, Thank you, everyone.
Thank you very much, sir, on behalf of Ima Karnataka State Branch. Shall we take questions now or shall we take in the end?
Sir, I think questions, if it is in the end, it would be better because it will be overlapping Nirmala's and Hamsa's
Hamsa's
presentation.
Yes, sir. That's okay, sir. Nirmala, madam. Madam, are you ready?
Yes, sir.
Yeah. I'll share your
I'll
slides
share
also.
Yes, sir. I'll share the screen, sir.
Yeah, madam. Slides ನೀವೇ share ಮಾಡ್ಕತ್ತೀರಲ್ಲ madam? Okay.
Yes, sir.
Yeah.
Is it visible, sir?
Yeah, chef, definitely.
Yes, sir. ಎಲ್ರಿಗೂ ನಮಸ್ಕಾರ.
Yeah, madam, you can enlarge. Madam, 1 second.
Yes.
Yeah. Here is Dr. Nirmala AR from Government of Karnataka. Can you hear me?
Yes, sir.
Yes, sir. Yes.
Yeah. She got her MBBS from Government Medical College, Mysore, and her MD from Dr. Ambedkar Medical College, Bangalore. She is working with the Government of Karnataka in the capacity as Director of Health and Family Welfare Services for the last 23 years. Under NTEP, supporting CDC labs and DMC's NAT sites in quality assurance. And she is also a supportive supervision to districts to strengthen the TB activities across Karnataka. And she is also associated with facilitating the NTP training at STDC as master trainer. Here is Dr. Nirmala here with us to highlight about the recent updates on diagnosis of tuberculosis, and also which will help in TB elimination program. Here is Dr. Nirmala to talk on this subject. Madam, please.
Thank you, sir. Thank you, Dr. Madhusudan, sir, and the entire IMA team for organizing this webinar. Today's my topic is on recent updates in the tuberculosis diagnosis. There are three methods in the diagnosis of tuberculosis. One is microscopy. The next is genotypic technique or the molecular technique where the Mycobacterium tuberculosis genome is identified and resistance is detected. And the third one is the culture-based test or the growth-based test where the bacteria are identified, whereby bacteria are identified and DST is done. So there are many modifications on these technologies. This is the journey so far. So even though in 1882 Robert Koch identified Mycobacterium tuberculosis, we were dependent on the microscopy through Zden method and its modifications. So and also X-ray. Later in 2005, we have the fluorochrome staining through Aramin staining. So it gives 10% extra yield compared to Zden microscopy. This is the added advantage, and the screening also is simple, and staining method is also very simple. So it is both the microscopy testing is economical, point of care technology, and one trained technician is sufficient to do the microscopy testing. The disadvantage of microscopy is the limit of detection is 10,000 bacteria per ml of the sputum. If less than that, we are going to miss the diagnosis. That is the disadvantage of microscopy. And also we are not going to detect the resistant pattern of any drug. These are the disadvantages of microscopy. Later we have in 2005 solid culture, that is the LJ media. These are the growth on the LJ media, Mycobacterium tuberculosis growth on the LJ media. Because it is very cumbersome, it takes longer time for the growth, almost 1.5 months for the growth, and for the DST again 1.5 months to 2 months. So it is discontinued, and that's the program we are using it as a backup technique. Later in 2010, we have the liquid culture system. So that is Mycobacterium growth indicator to 920. So here it is fully automated equipment. It gives the results within 10 to 12 days for the growth, and DST takes another 10 to 12 days. Within 1 month, we'll have the growth and also DST for all the drugs. Currently, we are using all the drug-resistant TB cases we are processing in this liquid culture system. So all the drugs, including the newer drugs, whatever the Bipal regimen drugs, bedaquiline, delarminate, even the protonomide, we have the DST in the liquid culture system. And later in 2011, we have the line probe assay test. This is a molecular technique where the Mycobacterium is detected. Along with it also gives results for the two important drugs used in the treatment of the TB patient, that is rifampicin and also INH. So, and also it gives the resistant pattern for the second line drug ethionamide. This is the ardent advantage of first line probe assay. Later in 2012, we have the CBNAT, Gene Expert or CBNAT. So it is almost revolutionized the TB program. So it gives the result not only for the Mycobacterium tuberculosis, but also one very important drug, that is the rifampicin resistance also. Within 2 hours, we'll have the results for the MTB and also rifampicin resistance. So it is completely closed system. There's no contamination, and the results are excellent. The one thing we have to remember in the CBNAT, it should have a continuous power supply, and also the machine and the cartridges used in the CBNAT system should be stored in less than 28 degrees centigrade. Somebody is talking. Sir, shall I continue?
Yeah, ma'am. Madam, please continue.
Yes.
John, look into it.
Yes. So currently, this is a 4-module machine. The machines are available 8 module, 2 module, 16 module, 32 modules also. So the limit of detection in this system is 131 bacteria per ml of the sputum. So compared to microscopy, the sensitivity and specificity is too good. All the samples can be processed in the CBNAT except frank blood. But the sensitivity varies from sample to sample. For the lymph node FNAC and biopsy, the sensitivity is 92%. For the pleural fluid, it is around 34%. It is the sensitivity of the CBNAT, but the specificity is 98%. Later, we have in 2020 the TrueNAT. It is a Make in India product from Malbio Diagnostic, Pune-based company. It is a 2-step procedure. First, it detects the Mycobacterium tuberculosis. Once Mycobacterium tuberculosis is detected, the second step for the rifampicin resistance, another chip is loaded to the machine. So the results will be same as 2 hours, and the sensitivity specificity is similar to CBNAT. Only thing we have to remember in the TrueNAT that a dedicated, well-trained LT should be there, because there are many small things in the TrueNAT testings. Yes, this is the Gene Expert. I already explained. This is a 4-module machine. This is the cartridge. For one patient, one sample, one cartridge we have to use. And this is completely closed system. So the sample should be processed. It is a very minimal processing procedure, and the cartridge is scanned and loaded to the machine. It gives the result automatically after 2 hours. So this is the TrueNAT machine. It is a single module machine, and this is the extraction machine. First year in the TrueNAT, we have to extract the DNA. Then we have to load the chip in this PCR machine. It is a 2-step procedure. One more thing in the CBNAT, regularly we are using the RIF assay. That is, it detects the rifampicin resistance. Again, once it is detected, we have the XDR cartridge. So once MTB is detected in the periphery with the CBNAT machine, with the same sample, remaining sample, one more cartridge is loaded. That is the XDR cartridges with the same machine. Will have the result for all these drugs within 2 hours, in the next 2 hours. That is for the INH, both higher level and low level resistance, and ethionamide, fluoroquinolone drugs, and injectable like amikacin, kanamycin, streptomycin. Within 4 hours, you will have the complete drugogram for the particular patients. So in the field, they can start drug sensitive and drug resistant TB patients with the by adding this XDR cartridges with the same CBNAT machine. This is the added advantage of the XDR cartridge. Currently in the program, it is not available. It is going to come. So line probe assay, I already explained. It is also molecular technique. It gives the result for both INH and rifampicin resistance. Sensitivity, specificity are too good. And in the first line, we'll have the INH resistance and also rifampicin resistance, and also ethionamide resistance will be detected. This is the second line assay. Here, the fluoroquinolone resistant and second line injectable drugs resistance will be detected. These are also PCR based technique, and the establishment of these labs is costlier. It is available under the program in 3 labs of Karnataka. One is Intermediate Reference Laboratory Bengaluru, and RIMS Raichur and KIMS Hubli, and also National TB Institute Bengaluru. One important thing we have to remember here is universal drug susceptibility testing. That means it is rapid DST for at least rifampicin and further DST to at least fluoroquinolones among all TB patients with rifampicin resistance. Strictly speaking, as a universal DST, we should have a complete drugogram for that particular patient. But under the program, we are offering rifampicin resistance and also fluoroquinolone resistance for RR cases. This is the universal DST, and I request all the practitioners At least your patient, drug sensitive TB patient should have their rifampicin status and also INH status. For drug resistant TB patients, they should have the drug resistant for rifampicin, INH, and also fluoroquinolone and injectable. These are the methods available in the program. Apart from these, there are many things in the pipeline. One is liporabinomane test in the urine. It is also WHO endorsed, but currently it is in the program. It is not available. It is recommended only for the PLHIV patient with low CD4 count. It is done with the urine sample. It is like our pregnancy test kit. So it gives the result within 20 minutes. It is going to help in the HIV individuals and also pediatric individuals. It is not there in the program currently. And also there are many modification and also are in the pipeline. They are going to come. And also we have the Shwasa app, cough apps also are in the pipeline, and AI. Just AI, and it can identify the presumptives. And further, we have to test these individual to confirm the TB diagnosis. So it is very important to collect the sample and how to collect the sample, where to collect, and also how much to collect. If we are not going to explain the patient what are the things to collect, how much to collect, they will collect only saliva. Even if we are offering a very high-end technologies, it is of no use. And also they have to collect minimum 2 to 5 ml of the sputum for the diagnosis of the tuberculosis for different tests in the program. And also, the sample should be mucopurulent and minimum 2 to 5 ml should be there. And these are under the program, we have the two collection tubes. One is the sputum container and the falcon tube or the conical tube. So for the culture-based test and the CB-NAT, we are using the conical tube or the falcon tube, and the sputum container for the microscopy and also TrueNAT. It is available in the program, and all our district TB officer are giving even to the private practitioners. And in the sample packing is also very important to prevent the leakage of the sample. So under the program, we are following the triple layer packing. First, the sample is collected and the outside is wiped with the 5% phenol. Then a paraffin tape is stick between the neck and the body of the falcon tube. Then it is covered with a cotton roll and it is placed in a Ziploc cover. And the annexure, that is the request form, is filled and it is separately kept in another Ziploc cover and it is transported to the nearing NAT site. If the sample is transported to the high-end labs like culture labs, so it should be kept in a thermocol pack with a freezer gel packs. Then it should be sealed and a biohazard sticker should be pasted on the box and it should be transported to the culture DST lab for the further testing. This is the algorithm we are using in the program that all the notified TB patients not offered RR-TB test. That means those are tested in the microscopy. So these samples should also come for the NAT testing, and those who are the presumptive, those we are suspecting TB, and also chest X-ray abnormal. All these individuals should be offered with the NAT testing and also non-responders to any regimen. So these samples should come to the NAT test. Here in the green line, we have one line, collect 2 specimens and test for resistance to rifampicin, INH, fluoroquinolone, or other drugs. That means these tests, they are recommending for the XDR cartridges. So currently it is not available. So we are offering regular NAT testing, either CB-NAT or TrueNAT for all the presumptives and the non-responders. In the NAT testing, we have the two results. One is MTB detected and rifampicin resistant not detected. Another is MTB detected and rifampicin resistant detected. These are the two results available from the NAT testing. Once MTB detected, rifampicin resistant not detected in the NAT, the next sample is escalated to the culture lab for the line probe assay, first line probe assay. So in the first line probe assay, we will have the result for the INH. If INH is sensitive, the patient will continue with the drug sensitivity treatment. If INH is resistant in the culture lab, the patient they will stop the drug sensitive treatment. They will start with the INH resistant treatment regimen. So in the culture lab, the sample will be inoculated into the liquid culture and the complete drugogram will be done in the culture lab. So depending upon the drugogram, the treatment will be changed. In the NAT test, if there is a resistance is detected to rifampicin drug, the sample will be escalated to the both first and second line LPA to the respective labs in the program. So in the lab, we'll do the both first and second line LPA and also culture DST. And they will start the treatment depending upon the resistant pattern. And the treatment aspect, Dr. Amsa is going to cover the BPAL regimen, other shorter and the longer regimens. So when any resistance is there in the culture, the regimen is changed accordingly. And it is very important to collect two samples. One they will use at the NAT site, another will be escalated to the culture labs. Yes, it is very important to transit from the smear microscopy to upfront NAT because the sensitivity is very poor in the microscopy. It is the need of the hour is rapid molecular test to identify the mycobacteria and start the treatment at the earliest. And now we are offering very high-end technology for the diagnosis of the tuberculosis, but the follow-up of the TB patient we are going with the microscopy. So it is very important to follow these individuals with the culture. So liquid culture is important for the follow-up of the TB patients and the decentralization of the rapid molecular testing. So whenever the patient comes to the health center, you should have the result immediately and start the treatment. So in Karnataka, we have 135 CBNAT mission placed at the district and Taluka hospital and some of the medical college. And we have the NAT mission even at the PHC level, UPHCs also, few sites. We are in the transition position. And the next thing is newer TB diagnosis like gene sequencing. It is very important to identify the complete genome of the MTB and also the to know the resistance to the available drugs. So that is the gene sequencing is very important, and under the program it is we are using for the surveillance purpose. Thank you.
Yeah, thank you, madam. Thank you for
Thank you, sir.
elaborating on the diagnosis of the tuberculosis. Madam.
Hello, sir.
Madam, are you there?
Yes, am I audible?
Yeah, you are audible, madam. Just 1 second. Network issues everywhere. Yeah. On behalf of Ima Karnataka State Branch, I welcome you to this webinar, madam. Just to introduce Dr. Hamsaveni. Presently, she is the WHO National Consultant for Drug-Resistant Tuberculosis, Central TB Division, New Delhi. And she had her schooling in Bangalore, MBBS from Nijalingappa Medical College, Bagalkot, her master's in community medicine in 2019 and DNB in 2020. Since 2016 itself, she is actively involved in TB patients' treatment. She contributed enormously towards the tuberculosis vaccine clinical trials at the National Tuberculosis Institute, Bangalore. And she joined WHO NTEP, that is WHO organization, serving in Kalaburgi, Ballari divisions from 2020. Amsaveni, apart from the regular periodic technical support to districts, she has played a key role in facilitating implementations of differentiated TB care, TB-free workplaces in many districts. She had actively collaborated with various departments of TB elimination efforts, showcasing the need of multi-sectoral accountability towards TB elimination. Currently, she is serving as at the WHO National Consultant for Drug-Resistant Tuberculosis since 2024. our association with IMA is very long, and I want to share one slide where, can you see?
It's opening. Yes, sir.
Yeah. See, this is our association with Madam for the last 5 to 7 years, where during the period of COVID, the concept of webinar online classes were very much initiated by IMA Karnataka State Branch, and we had our own Zoom platform we have purchased, and this was introduced during that period, very hard times, where she spoke on the role of IMA and government in TB eradication. As all of us were uh, concentrating on the COVID, we never forget the tuberculosis as such. We had around 7 to 8 series of webinars on this subject. So here is Dr. Amseveni to speak on drug-resistant tuberculosis and the overall management of tuberculosis. Over to you, madam. Will you share your slides, madam?
So can you please share, sir?
Yeah. You want me to share? Yeah.
Yes, sir. So by the time you share the slides,
Yeah.
this made my day actually, sir, because I have learned so many things from the field. I'll be wrong if I don't remember that my experience from Karnataka, basically. Might be it's from Anil sir, the clinical experience, the way he explains and the way he addresses the difficult to treat or diagnosis the TB cases, or Nirmala ma'am being a pioneer in NABL accreditation of all the IRL labs in Karnataka, and especially from the Kalburgi and Ballari division. My majority of the days of field experience was from Ballari. So the district TB officer, Dr. Indrani ma'am, and Madhusudan sir from Siruguppa. I still remember the day. Actually, it went on the discussion till the midnight, 12 o'clock in a IMA sensitization. All these days, absolutely, we were like thinking very kind of, not such a depth of technical discussion. But that was one kind of an eye-opener to me, where a physical IMA sensitization, which started around 8:30 or 8, something like that, and it continued till midnight, 12 o'clock. Only the technical discussions. And I was actually blown away from that. And that's how we started with this webinar. Thank you so much for those memories, sir, again.
Can you see?
Yeah.
Yeah. Is it visible?
Yes.
Yeah, madam. Please.
So, and what is the time I do have, sir? Because it's already 10:05. I just wanted to know so that
Yeah,
I can manage
10:20.
that. 20.
15
Okay,
minutes
sir.
we can take, madam. 10 minutes
Sure,
we
sure.
shall use it for discussion.
Noted, sir. Done.
Yeah.
ಸೊ ಎಲ್ರಿಗೂ ನಮಸ್ಕಾರ. ಸೊ ಆಗ್ಲೇ ಹೇಳ್ದಂಗೆ ಇವತ್ತು ಯಾಕೆ ನಾವು ಡ್ರಗ್ ರೆಸಿಸ್ಟೆಂಟ್ ಟಿಬಿನೇ ಜಾಸ್ತಿ ಹೈಲೈಟ್ ಮಾಡಿ ಹೇಳ್ಬೇಕಾಗುತ್ತೆ ಅಂತ ವಿ ಆಲ್ at least we have to understand what is the background basically. Being in India in a public health or in a clinical setup, we forget what's happening across. So this slides tell us about, it's a recent 2024 global TB report where India is contributing to 26% of the total estimated burden, and coming to the DRTB, it is 27%. And coming to the mortality again, NTB target bandu, one the incidence reduction irutte and mortality reduction irutte. So both of these indicator is very high in India. For example, if there is some 3 TB deaths across the globe, the third person will be from India. That is the intensity of the TB contribution from our country. That is the reason we have to collaborate. We have to see as much as possible we can contribute towards this TB elimination. Next slide, please, sir. So this is the type of a TB definition. I don't think so this needed in depth of it. So please next slide. Based on the resistant pattern, we have just divided into H mono, that's isoniazid, or along with isoniazid, if rifampicin resistant, it's a multi-drug, and pre-XDR and XDR. This is how based on the resistant pattern. And let's understand this in perspective of National Drug Resistance Survey, which happened in India 2014 to 16. Because of irrational use of antibiotics, today AMR is taking away almost 4.5 million life across the globe. In that scenario, definitely TB is one of the major driving drug-resistant public health to be addressed at the immediate action. Coming to the Indian scenario also, this survey, it is again reiterates telling that among 4,958 TB cases, its resistant for any drug is 28%. So we have already used so many antibiotics and we have actually ignited that resistant pattern in the system, in the community. So we can see 28% of the TB cases are resistant to any of the drugs. Coming to specifically multi-drug, when I tell it's multi-drug, it's about isoniazid and the rifampicin, which is an important first-line anti-TB medicines used for a treatment of tuberculosis. So in this scenario, it is 6.9%. I would like to much more sneak here, telling that when I tell it's a 6.9 among all TB cases. Among the previously treated cases, we can see there is a 11.62 is the resistant pattern. That's a MDR TB cases among previously treated, because there is already an exposure of antibiotics and we are not sure about the adherence and we are not sure about the completion, absorption. There are so many other clinical scenario. But look at these new TB cases where 2.84 of the new TB cases are turning out to be MDR TB patients without even exposure for specifically any TB drugs. And coming to the pre-XDR, where it's a resistant pattern for the isoniazid, rifampicin, and any fluoroquinolones. In that scenario, it is 21.82% of the TB cases are pre-XDR. So this is one highlighted survey which drives us towards this drug resistant and says that we have to break this chain of transmission of this DRTB. Next slide, please, sir.
It's not moving. I'm trying.
Yes.
Ah. Is it?
Yeah, sir. So please, next slide. This is the journey, how exactly the TB program started and expansion of the DRTB services started in 2007. And now we are in the shortest, that is a 6 months of DRTB regimen. Days were there where 36 months of DRTB regimen was actually initiated earlier stage in 2017 and 12. And now we have shortened it to a 6 months. And when we tell it is shortened, the duration of a treatment regimen is shortened, we never compromise with the outcome of the cure rate as well, or success rate, or even the recurrent cases. With all this standard setting, we are having a very effective regimens in present scenario. Next slide. So this is a national overview where we have 6 National Reference Laboratory and 37 IRL. Being specific for Karnataka, as already told, we have 3 IRLs and 1 NRL, that is NTI in Bangalore. And almost every district has nearly like 3 to 6 NAT, CB NAT specifically, and now 2 NAT has been scaled up. And Nirmala ma'am, who is a pioneer in this lab strengthening, she almost have given the how exactly the picture of the diagnostic tools are existing in Karnataka. Next slide. So, and one more to highlight is regarding the DRTB treatment center. Here we can see in Karnataka, there are 6 nodal DRTB centers where you can actually have a consultations for a difficult to diagnosis or treat any kind of a DSTB or ADRs or even the DRTB. And almost every district will be having a DRTB centers. So this is the trend of the how exactly the DRTB is detected. In 2023, the nation detected 6,986 and overall, being specific for Karnataka, approximately 1,300 to 1,400 will be the every year MDR TB patients will be diagnosed here. Next slide, please, sir. Coming to the treatment success rate, this is the impact of introduction of a evidence-based newer regimen. This is where I wanted to highlight for today's session, where it tells there is a improvement year on year. We can see for the H mono, present scenario, 87%. It's a published data from the annual TB report. 87% is the successful outcome. Whereas coming to the MDR TB treatment, it is 72%. It has been improved from 49% in 2017 till 72%. And there is also a very good development in the pre-XDR TB patients outcome as well. That is 68% in today's scenario. Next slide. So one thing we may have to understand when we tell that we have to break the chain of transmission, I can tell that DRTB is the low-hanging fruit. So can we break the chain of transmission of the DRTB is one thought process we can actually comes into our picture. So when I tell to break the chain of transmission, we should be knowing what exactly DRTB and where are they generated so many. So looking at the cause of DRTB, the first one is the genetic mutation. And it's been highlighted in a blue color where if there are bacilli 10 to the power of 6, we can expect isoniazid to be resistant. In the scenario, that is the first antibiotic, that is the first anti-tubercular medicines for which the resistant pattern is developed because of this genetic mutation. And if the bacilli load is increasing to the 10 to the power of 8, then the rifampicin resistant develops. And further, when it is 10 to the power of 14, that's when the MDR sets up. So when there is a bacilli load increase, there is a more chances of genetic mutation. That is the reason we always, the program intention is for the early diagnosis and appropriate treatment. So when we delay our diagnosis, there is a chances that bacilli load will be increasing, and this first cause of the DRTB do exist there. And the survey also tells that the same National Prevalence Survey also tells that nearly 49.7, approximately 50% before getting diagnosed as TB will be reaching the private sector. So that is where we need to emphasize to early diagnose the cases. And the second one is inadequate supply or the poor quality. So this is one thing. When we tell it's an inadequate supply, non-availability of drugs or the poor quality or even the poor storage conditions or a wrong doses and the combination. As already told, like Dr. Anil has beautifully highlighted, when we give a monotherapy for the prevention aspect, it is for the preventing the drug for multiplication. It is not as per the treatment of a TB disease per se. So though the bacilli is there in our body, that's the infection mode is already on. We are not letting that bacilli to multiply. That's where we are actually breaking down. The sleeping mode is being prolonged in that scenario. So if we give this kind of a monotherapy or wrong doses, inadequate doses or an inappropriate combination to the different kind of resistant pattern TB, absolutely we are not treating them adequately. That is one important thing. And already told, poor storage, if it is there is a spillage and all these things has to be mattered. And in the NTEP, the drug supply will be a WHO standard quality. PQLI will be passed from the WHO, from the manufacturers till the supply and even the post market where the patients are utilizing as well. And further, the providers are the program inadequate regimen. If it is not supervised appropriately, we always insist on the directly observed treatment, because many a times, whatever the technical adherence would have been developed, at the end of the day, the human touch, the directly observation and counseling to the TB patients till the patient completes the treatment matters a lot. And this has played a major role and the evidence has been generated. The outcome will be comparatively in a better positive way, and also the recurrence will be reduced. And the absence of the guidelines or inappropriate guidelines implementation, I don't think so Karnataka gives a space for such things. And non-compliance with the guidelines, inadequate training of the health staff. All these things are a policy-based or a programmatic base, and no monitoring of treatment or poorly organized or the funded TB control programs. So further going to the inadequate drug intake, as already told, in public health, we have a triangle called as host, agent, and the environment. Once we are speaking about the agent that is multiplying very rapidly, and the other way we are addressing the environment, which is actually making them multiply better way, might be a vulnerable population or might be a close transmission setting is already been set up. And coming to the host factor, when I tell host factor, might be the program is working appropriately 100%, and might be the based on the resistant pattern, the treatment is being given appropriately, but still we are actually looking these DRTB cases. Why? Because might be that's the host factors which is actually taking a long way, where there is a malabsorption or lack of information or poor adherence. There is no non-availability of free drugs, adverse drug reaction which is not being addressed properly. So, and so substance abuse disorders. These are the things which actually highlights the host factors and pushing this person towards the DRTB. So next slide, please, sir. So how to prevent this DRTB? One is, as already told, the early detection and the treatment of the drug-resistant TB with appropriate medicine plays a very vital thing. One way about the treatment part. Coming to the prevention part, which is already again Dr. Anil has highlighted. Based on the resistant pattern of the index case, the contacts will be treated with the preventive regimen. So this will be a highlight where there is a break of chain of transmission. For example, it is told, the evidence has told, based on the genetic sequencing, if the contact is breaking down toward TB disease, majority of them, approximately 70% will break down in the first 2 years and 85 to 87% will be breaking down to the next 5 years. So if you protect this household contact by not breaking down to a TB disease for this 5 years, definitely there will be an efficient way model of breaking this chain of transmission. That can be, one is AIC, following appropriate AIC. It can be a personal AIC or the environmental AIC in the residence, as well as in the high risk settings like in hospitals or in the lab. And the second way is by preventive therapy. So next slide, please, sir. So with this background, consistently, WHO gives the guidelines based on the evidences generated across the globe, across the country. And this guideline will be adopted to the national level based on the local, that population sequence. So as Anil sir told, it was a BPAL. There is a story from 2014 to 16 where next trial started, then the Xenix trial started because of the adverse drug reaction. That's when the BPAL was actually, the news of the BPAL set in. So when we address that, India had actually conducted a MBPAL study. That's a modified BPAL study. Later on, after this ICMR inputs, after this NTG, that's a National Technical Expert Group inputs, finally it was a BPAL-M policy which was being adopted and been scaled up in the policy now. So based on this, for this, there was a new guideline, national guidelines for PMDT, management of the drug-resistant TB, 2024 was released. And this is just an overview which tells about case finding and diagnosis, which is briefly discussed earlier. Let's go in depth about the treatment part of this drug-resistant TB. So next slide, please. So this is one algorithm, which is an integrated diagnostic and treatment algorithm for the drug susceptible and resistant tuberculosis. So here the attempt is to try the DS, how to diagnose the DSTB, and further how to diagnose the DRTB and which regimen to be considered. So first to identify, as already discussed, now it is no more a 4S symptom, it is a 10S symptoms. So all notified TB patients not offered RR TB test. So we are expecting RR is rifampicin resistant TB test. So all notified TB patients must know their rifampicin status, because it's rifampicin being the first line anti-TB drugs. The basic understanding whether it is resistant or susceptible is very, very important. First point. The second thing is all the presumptive TB or the persons, including abnormal chest X-ray with or without symptoms. Now, the recently, few weeks back, there was a document which was released by the World Health Organization about the asymptomatic TB as well. So when I tell it's an abnormal chest X-ray with or without symptom, highlighting again without symptoms, we may have to think that, is this a asymptomatic TB? Question mark. Because you being the frontline warriors to identify this asymptomatic TB will be very pioneer to identify these people and put them in appropriate treatment. And the third category being a non-responders to any of the regimen. In that scenario, again, the rework has to be done, whether there is an amplification of resistant pattern or not. In all these first three boxes, we are supposed to collect the 2 specimen, as Nirmala ma'am already told. So we are supposed to test for, one is rifampicin, mandatory, which will be tested by the NAT, which is available at the taluka and the district hospitals. And the second one will be the isoniazid, which will be sent to the IRL labs, and the fluoroquinolones. So based on this report, further we have to decide whether they are drug susceptible or drug resistant, right? So in the scenario where there is an MTB detected, that's a Mycobacterium tuberculosis positive, and resistance is not detected. The first one, the NAT has been developed telling that rifampicin status. So here we are mentioning only about the rifampicin status. If the report tells MTB is positive, but rifampicin resistant is not detected, in that scenario, we do consider it as a drug susceptible TB. So what is the regimen for that? As we all know since ages, it's a 2 months of HRZE with 4 months of HRE. This is very clear. Then meanwhile, the second sample will be sent for the IRL, and we look for the isoniazid resistant pattern. If isoniazid resistant pattern is not detected, I mean resistance not detected, meaning it is sensitive for isoniazid. In that scenario, it is purely a DSTB, then complete the 6 months of DSTB regimen. This is clear on the yellow color on the extreme right side. If at all this H-resistant test is detected, that means whatever we are giving HRZE, the resistance is already developed. We are removing H and replacing it with the levofloxacin. So the regimen becomes LRZE. And there is no IP or CP phase in this. It's a continuous 6 months of LRZE. Right? And further, that is not the end of the day, because there is something called as universal drug susceptibility testing. The person with TB must know that isoniazid pattern, rifampicin pattern, fluoroquinolones in a complete scenario. So if there is an additional resistance, the patient is already a H resistant. That means H mono or poly resistant. If there is an additional resistance or intolerance or non-availability of any drug, think on H mono or poly DRTB regimen modified as per the replacement sequence. For example, if levofloxacin is not available, there is group A, B, and C, which is introduced since 2021. So saying you can go for a replacement. The levofloxacin, if it's not available, look for the moxifloxacin. So the regimen becomes MRZE. So this is what the guidelines tells now. And still clinically the patient is deteriorating. And still there may or may not be this amplification. Please look for the second line LPA. If RR detected, then it is obviously an MDR, because H is already a resistance. And in the second line LPA, that is, we are finding it as a rifampicin resistant also, then it's an MDR. If rifampicin resistant not detected also, the clinician will have a call to consider it as a probable MDR TB patients, because might be there is a contact of MDR in their house or in the workplace, or the clinical picture itself is telling it as a MDR, probable MDR. Then this will move to the left side of this diagnostic. So I guess I am clear on the right side being DSTB and H mono or poly resistant TB. So just a minute, sir, the previous one. So in this scenario, coming to the left side of the box, if the MTB is positive, that means there is a TB and the rifampicin resistance is detected. So it becomes a MDR TB, because as already told, the evidence have told that the first anti-TB medicines for which there is a resistant pattern is first is isoniazid, then comes the rifampicin. That's what the evidence tells. So if it is RR, it is a MDR TB case. So in that scenario, somebody were asking even in the chat, some information about the pediatric also. Here is the information. In the right side, it is more or less the same thing. Based on the weight band, the dosage will change. Otherwise, nothing else. Coming to the left side, and the MDR TB patients, we are very specific telling that if the person is above 14 years, look for the eligibility of BPAL-M. If the person is less than 14 years, then BPAL-M can't be given. That is in the pediatric age group, we can't give the BPAL-M. Then the next option will be, we have to look for the eligibility of shorter oral regimen. Fine. So, if the person is above 14 years and you have looked for the eligibility of BPAL-M and everything is ticked, then start with the BPAL-M. As already told, BPAL-M has 4 drugs, that is bedaquiline, tritonamide, linezolid, and moxifloxacin. There is no permutations and combinations. To the max, linezolid, which is given 600 mg, initial 2 months must be a 600 mg only. If at all there is an ADR, then you can reduce it to 300 mg. Otherwise, there is no permutations and combinations with the dose or in the combination of these ATTs, right? Further, you will complete this regimen. Then, if at all a person is not eligible for the BPAL-M, the second preference will be given for the shorter oral regimen. Shorter oral regimen, we used to call it as a Bangladesh regimen, which was very specific. Again, we were not allowed for the replacement of the any medicines here. So the newer evidence here also, this is another important new policy which has been pitched in, where ethionomide, which was a part of this Bangladesh regimen, can be replaced with, the 4 months of ethionomide can be replaced with 2 months of linezolid, right? Why is this? This helps us, even for a pregnant lady, will be eligible for this 9 to 11 months of regimen. Because when we go for the eligibility, we'll go in detail. We can share this slide as well, where the BPAL-M eligibility criteria will be highlighted. Further, if the person is not even eligible for the shorter, then the last option will be the longer. That is bedaquiline, linezolid, levofloxacin, clofazimine, and cycloserine. And the duration will be 18 to 20 months. Here, based on the resistant pattern, there will be an option of replacement as per the group A, B, and C. Next slide. Any doubts or anything, let us please know on chat box. So we have already highlighted. I guess you can move ahead after this algorithm. Yes. Next slide, please, sir. So this is what we were highlighting. This is another important new policy change which has happened here. We have to understand what are the eligibility and the exclusion criteria for this BPAL-M. First one is inclusion criteria, as already told, above 14 years only. It's a new microbiologically confirmed MDR or RRTB cases. Then, further, if there is a history of exposure of less than 1 month of intake of bedaquiline, linezolid, tritonamide, or in the past. If at all, if it is more than 1 month, also still eligible, but definitely to be looked for the sensitivity of the drugs of all this bedaquiline, linezolid, and tritonamide. Then person who had failed treatment with the bedaquiline or linezolid containing a shorter and the longer regimen, that means already he had taken some shorter or the longer regimen, but still when we look at the resistant pattern, they are sensitive. This bedaquiline and linezolid are sensitive. Definitely BPAL-M can be given to this person. And third important is, if the corrected QTF ECG is among the males, it should be less than 450. And among the females, it should be less than 470 milliseconds. In that scenario, to be given, if it is high, then look for the electrolytes. If there is an abnormality in the electrolytes, serum electrolytes, then you have to correct it and again redo this ECG and look for the corrected QTF. And if there is coming to the standard of less than 450 among males and 470 among females, do start with the BPAL-M. Coming to the women, please kindly understand, a non-lactating woman, or might be the woman is in a lactation, but she is not breastfeeding. They are eligible for the BPAL-M, first point. The second point is, she is a non-pregnant, and again, if at all she is a pregnant, less than 20 or 24 weeks. This or 20 or 24 weeks is based on the recent AMTP amendment. So if there is a pregnant woman with MDR diagnosed, who is less than 20 or 24 weeks of gestation and willing for the medical termination of the pregnancy. That is very important. As per the MTP Gazette notification, again, there will become the eligibility for this BPAL-M. So more or less, you can see almost all the TB patients, whether it's a pulmonary or extrapulmonary, all these patients are eligible for this BPAL-M. So I missed the slide. Can I get just some 4 minutes? I shall wind up, sir.
Yeah, 1 minute, madam. There is a technical edge. Yeah.
Okay. So coming to the exclusion criteria in pediatric, less than 14 years, as per the policy, today we don't have this BPAL M for less than 14 years, one mandate thing. And second thing is the severe extensive form of TB, like CNS TB or brain CNS disseminated TB. These are not eligible for this BPAL-M. Otherwise, if it's a simple EPTB is also eligible for this BPAL-M. This must be clear from our end. So shall I wait or shall I go ahead, sir?
Yeah. You want me to? Madam?
So no, sir, the screen is not visible.
Now?
No, sir. No, sir.
No. It is there. I can see.
No, sir. It's not share. Just if you can stop share and reshare once.
1 second. Can you hear me?
Yeah, sir,
You're
clear.
audible, sir. You're audible.
But I am sharing this slide. It is on my screen.
No, sir. It's not come on Zoom. Just stop share, sir. Once.
1 second.
Yes, sir. That's on your TV. Yes, sir. Now it's open. Yes, sir. Full screen.
Okay. This is the one.
Inclusion
see?
and exclusion. Yes, sir. Next slide,
Yeah.
please. Yeah.
This is the one. Yeah.
So this is one thing. And as already told, exclusion criteria, we usually tell LFT, if it is more than 3 times of the upper normal limit, to be considered for the evaluation. And once you address the liver function test and the enzymes come back to the normal, definitely you can start with the BPAL-M. And severe form of extrapulmonary like CNS TB, spinal or skeletal, and disseminated TB. This will be eligibility exclusion criteria for the BPAL-M regimen. And significant cardiac conduction abnormality also not to be considered for the BPAL-M regimen. Next slide, please. Next slide, sir. So this is one important to be highlighted, the dose. So as already told, the BPAL-M contains the 4 medicines, that's bedaquiline, pretonomid, and linezolid and moxi. Bedaquiline, as we give in the present scenario, first 15 days, that's 2 weeks, 400 mg daily. That's we'll have 100 mg of tablets. So 4 tablets every day. And after 3rd week till 26th or 39th week, it is 200 mg 3 times a week, alternate. And further, pretominid, it is a newer drug which is not available in any of the private pharmacies. It's presently in the conditional access in NTP, that's a TB program. So this will be a 200 mg. One tablet will be 200 mg, it's a standardized. So this will be every day 1 tablet. And coming to the linezolid, as I already told, it is a 600 mg daily. If the patient can sustain with a 600 mg daily for 26 weeks or 39 weeks, that is 6 months to 9 months, that can be given. If at all there is an ADR or peripheral neuropathy or any other ADR based with linezolid, bone marrow suppression or something like that, then there is a scope of reduction only after 8 weeks, not before that. Then comes the moxifloxacin, where 400 mg daily has to be given for this 6 months complete. I guess I'm clear. And one more, the policy is we have to give the pyridoxine along with this regimen. So next slide, please. And the second preference, that is the 9 to 11 months shorter oral MDR RRTB regimen, which was already called as a Bangladesh regimen. And we had earlier the B-Ero. Kindly look at that. That's 4 to 6 months of levofloxacin, clofazimine, etionamide, pyrazinamide, ethambutol, high-dose isoniazid, and 6 to 9 months of bedaquiline. And in the CP phase, continuation phase, it was 5 months of LCZD, that is levofloxacin, clofa, and pyrazinamide and ethambutol. The one change here is we have taken out this etionamide. This is the alternate method, the first priority now. we have taken out this 4 months of etonomide and replaced with 2 months of linezolid. So that because of this etonomide in this regimen, that is in a B row regimen, this regimen we were not able to give it for a pregnant ladies or up to 32 weeks because of its own side effects. So now even the pregnant ladies are eligible for this shorter 9 to 11 months regimen where we are giving linezolid, not the etonomide in this combination. Next slide, please. And I saw so previous slide, please. I saw some questions asking what is the treatment for the CNS TB. Might be I have missed many chats, but this was highlighted. So now the CNS TB will directly go to the all oral. Next slide, please. So this 18 to 20 months longer oral, this stands the same way as we had in 2021 guidelines, where there is 6 or longer months of bedaquiline plus 18 to 20 months of levoflox, linezolid, clofa, and cycloserine. And here, based on the resistant pattern, based on the other criteria, there is a scope of replacement as per the Group A, Group B, Group C, which is mentioned in guidelines PMDT 21. Next slide. So as already mentioned, so among the pregnant and the lactation, which was already there in the flow chart as well, now the shorter regimen, 9 to 11 months shorter regimen can be given, but please make sure that instead of etonomide in that combination to be replaced with 2 months of linezolid. That is one important point. And if the woman is ready for the MTP, that is less than 20 or 24 weeks as per the MTP Gazette notification, definitely they'll be directly eligible to the first preference, that is the BPAL-M. Next slide, sir. So this is the way, if the duration of a pregnancy is more than 20 or 24 weeks, and the MTP, we can't do MTP in such conditions. Definitely the preferences of regimen will be 9 months of shorter oral MDR or RRTB regimen, and make sure that it should be with linezolid. And the second preference will be longer oral M or XDR-TB regimen. If the duration of pregnancy is less than 20 or 24 weeks, advice for the MTP, counsel for the MTP. If MTP is done, definitely BPAL-M for 6 months. Next slide. So in children, as already told, less than 14 years, we can't give the BPAL-M. So here, 9 to 11 months of shorter regimen or 18 to 20 months of longer regimens will be holding good. And would like to highlight for those, this is in line with the 5 to 14 years of age. If it is less than 5 years, there is no regulation for us, like we are looking forward. In fact, the bedaquiline is not available for less than 5 years. So in the shorter regimen, the bedaquiline is replaced by amikacin or kanamycin. In the longer regimen, it is replaced by telamine. This is one important thing to be noted down among the children. Next slide, please, sir. Among HIV, more or less, yes, the BPAL-M holds good even for the HIV. Need not worry on that. But only one important thing to be taken care is CD4 below 100 cells has to be taken extra care, cautious before starting this. Next slide, sir. And anemia, as already told, this is one important. Here, the culprit I can call you the linezolid, where there is a bone marrow suppression. A very keen, meticulous follow-up of the patients to be looked at, especially the HB level, where there is a drastic decline. And hence, if there is a anemia or because of linezolid or peripheral neuropathy, linezolid has to be taken care there. And if there is a HB less than 8, you stop this regimen, make sure that address this anemia first. If at all above 8 grams per deciliter, then to reinitiate with the BPAL-M. Next slide, please. Next slide. So I tried maximum to cover in the short durations. Definitely, we can share this PPT. Any questions or anything? Please put forward on the chats or questions.
Yeah, thank you very much, madam. On behalf of Karnataka State Branch, I think each topic needs 1.5 hour discussion, definitely, because you tried your level best to put them in a nutshell. Thank you very much. Definitely, it needs lot of our what do you call insight into the topic, because it was very fast and also very difficult for us to follow. And probably, definitely, we can cover these topics in a different. We can make it as a series in the coming days, so that definitely this disease has to be tackled by irrespective of the specialties. There's a surgeon, physician, neurosurgeon, pediatrician. Everybody needs to learn about these things. Thank you very much. Any questions to the speakers?
Ma'am, I have a question. Is
Yeah,
there any
please.
role of trial of ATT? Because earlier, more than 2 weeks of fever, not responding to anything, do all the investigation basically normal as a PUO diagnosis. So give trial ATT. So is there any role of still that?
So can I take a moment to call like Dr. Anil sir if he's in the webinar, sir? Because there is a physician.
Dr. Anil?
Yes, sir.
Yeah, he is there, sir. Sir.
So the question is PUO.
PO, many causes
Can
for PO?
Trial ATT. Earlier,
No,
we used to have trial ATT. Like you
sir,
just put them.
I know. I got your question, sir. There is nothing called trial ATT now. If somebody is put on, if you think that this patient has TB, go ahead and treat him as full dose of TB. This is a very common question that like one of my professors also used to tell that if you think this is TB, start him on INH. If fever comes down, then put him on full dose of drug. Now that has, if you look at probably what Hamza showed, primary INH resistance in India is to the tune of 27%. So, sir, two things in TB treatment, sir. No monotherapy. And the second very important dictum in TB is never add a single drug to a failing regimen. So if you think that this patient is not responding to the treatment, we actually end up adding one more drug. Like you would have started him on AKT4, then you think that this patient is not doing good enough, then add levofloxacin. Then you think still he's not doing good enough, remove rifampicin, add cycloserine. This jeopardizes the patient profile itself. So he should be reassessed and restarted on treatment.
Thank you, sir. Madam,
Sir,
Nirmala madam. Nirmala madam.
hello.
Nirmala madam.
Yes, sir. Yes, sir.
Madam, why this falcon tubes are conical? Very basic
Sir,
question, because it is very difficult for patients to carry them, to keep on a
sir,
table.
yeah, for the centrifugation and other culture work, it requires, sir, these falcon tubes.
Because patient
So it will
complains
not
that
fit,
they
sir.
cannot keep it
Otherwise,
on table, or very difficult because they will
yeah.
fall on the the surfaces.
Sir, further testing it is required, sir. So sputum cups usually we don't use in the culture labs, sir. Even for the CB0 we will not recommend. So we have to vortex these samples. That is, we have to mix the samples by vortexing, and also centrifugation is required for the culture, sir. So
Yeah.
here the Falcon tubes are required, sir. We don't accept with the samples in the sputum cups for the culture testing, sir.
Yeah, got it, madam.
So
This is
yeah.
a grievance by the patients, not by the doctors.
Yeah.
Sir,
Madam,
ಇದು grievance
madam,
by the patient.
just
ಏನಾಗುತ್ತೆ ಅಂದ್ರೆ
hello,
ಸರ್ ಹೇಳಿ ಸರ್.
ಸರ್ ಇದು
ಚಿನ್ನಿವಾಲ ಸರ್ ಒಂದು ನಿಮಿಷ.
hello,
ಚಿನ್ನಿವಾಲ ಸರ್ ಒಂದು ನಿಮಿಷ ಇರ್ರಿ.
ಹಾ.
ಚಿನ್ನಿವಾಲ ಸರ್ ಒಂದು ನಿಮಿಷ.
ಹಾ.
ಅನಿಲ್ ಸರ್ ಆನ್ಸರ್ ಮಾಡ್ತಾ ಇದ್ದಾರೆ. ಸರ್ ಹೇಳಿ ಸರ್ ಅನಿಲ್.
ಎಲ್ಲ ಏನು ಸ್ಯಾಂಪಲ್ ನಾವು ಕೊನಿಕಲ್ ಟ್ಯೂಬಲ್ ಹಾಕ್ತಿವಿ, ಇಟ್ ಈಸ್ ಸ್ಟ್ಯಾಂಡರ್ಡೈಸ್ಡ್ ಬಿಕಾಸ್ ಆಫ್ minimal handling of the biological sample. TB is airborne infection. Aerosolization ಆಗುತ್ತೆ. ನಾನು ಒಂದು ಈ ಟ್ಯೂಬ್ ಇಂದ ತೆಗೆದು ಆ ಟ್ಯೂಬ್ ಇಂದ ತೆಗೆದು ಈ ಟ್ಯೂಬ್ ಹಾಕತ್ತಾರೆ. ಅದಕ್ಕೆ ಒಂದೇ ಟ್ಯೂಬ್ ಅಲ್ಲಿ ಇಟ್ಕೊಂಡು ವರ್ಟೆಕ್ಸ್ ಮಾಡಿ ಅದು ಸೆಟ್ಲ್ ಆದ್ಮೇಲೆ ಅದನ್ನ ವಿ ಪ್ಲೇ ಅರೌಂಡ್ ವಿತ್ ದ ಸ್ಯಾಂಪಲ್. ಹಾಗಾಗಿ ವಿ ಯೂಸ್ ಫಾಲ್ಕನ್ ಟ್ಯೂಬ್ ಆರ್ ಕೊನಿಕಲ್ ಟ್ಯೂಬ್ಸ್ ಆರ್ ಫಾಲ್ಕನ್ ಟ್ಯೂಬ್ಸ್.
ಎಸ್ ಸರ್, ಸರ್ ಥ್ಯಾಂಕ್ ಯು. ಚಿನ್ನಿವಾಲ ಸರ್.
Just I want to know regarding the diagnosis and investigation of the extrapulmonary tuberculosis, especially abdominal and genitourinary tuberculosis. It is very difficult to diagnose in the initially. So how to? Number one. Second, if the patient is taking a treatment in ATT, if there is no improvement at that time, along with the ATT, we have to add this Pipalam or only Pipalams.
Sir, BPAL-M is a different regimen altogether.
Yeah.
That is what we were trying to tell. If the patient is diagnosed as a drug susceptible TB, then it is only 4 drugs: INH, rifampicin, pyrazinamide, ethambutol, 2 months of intensive phase, and minimum of 4 months of continuation phase. So BPAL regimen is given to MDR TB or rifampicin resistant TB, pure rifampicin resistant TB. So we cannot mix both drug susceptible and drug resistant TB regimens. To your first question on abdominal TB or genitourinary TB, abdominal TB, what type of abdominal TB are we looking at? Are you looking at retroperitoneal lymph nodes? Are you looking at ileocecal junction? What is it? Or that needs to be answered. First is the confirmatory diagnosis or clinical diagnosis. Confirmatory diagnosis comes with tissue sample. Sir, one very important thing that we want to tell you is if the sample is precious, like you have done all the way to reach ileocecal junction, taken a biopsy, the biopsy should be immediately transported in a normal saline to the culture labs only, where, as Madam Nirmala told, we will grow the TB sample. Once we get the culture growth, then we will give you the result. So the it is it will take some time, but it will give you a definitive diagnosis. You will get a drugogram. Suppose you give it to CBNAT and I have used the sample and it comes as TB and it is showing rifampicin resistant TB, then I will not be having the sample to process it. So if any sample, whether it is mastoid, whether it is your pericardium, other than fluids, all tissue biopsies, I request it can come to the culture labs for growth. Once growth comes, then they will give you the result.
Sir, one
Sir,
more.
Thank you.
hello. One more question.
Sir, one
Hello.
more.
Sir,
With
Srinivas sir,
uric fluid or
ಬೇಕಾಗುತ್ತೆ.
acetic fluid. Hello. Sir.
Hello.
Sir, Bidinal.
Yes, Dr.
ಹೇಳಿ sir.
GB Birnal.
Yes.
I am a
ಹೇಳಿ
national
sir.
vice president, sir. Congratulations to all the speakers for informative talk. Really, it is an informative talk. It should all our IME is with you to eliminate this TB. Definitely, we learnt about the new things. Really, that the
Sir, question sir.
regimen.
Sir, question. Any questions?
Question, yes. In miliary tuberculosis, the same regimen will apply, or we can add some other drugs?
No, sir.
Miliary tuberculosis.
Any TB, sir, miliary, whether it is miliary or non-miliary or cavitating TB, these drugs are sufficient, sir. Sir, yes, sir. If sir, the first line drugs, INH, rifampicin, ethambutol, and pyrazinamide, even to this day, are the best drugs in treating TB. All the other drugs, except for bedaquiline, delaminate, and pretominate, all the other drugs are repurposed drugs. These are the drugs that are, what Hamsa was showing, that if you look at the kill rates or resistance rates for INH, it is 1 in 10 to the power of 6. For rifampicin, it is 1 in 10 to the power of 8. For pyrazinamide, it is 1 in 10 to the power of 8. For ethambutol, it is 1 10 to the power of 6. Theoretically, if you want to have bacilli resistant to all the four, if you add up, it will be 1 in 10 to the power of 24. Even in a cavity, you can see 1 in 10 to the power of 10 or 1 in 10 to the power of 8 bacilli only. So if you put the first line drugs, appropriate regimen, patient is sticking on to the treatment, you have addressed his comorbidities well. He does not have hyperglycemia, he has stopped tobacco, he has stopped consuming alcohol, good nutrition supplement. Obviously, they all will respond, and the relapse rates can also be minimized. Today we have around 6 to 8% relapse in TB. Even that can be minimized, sir.
And Anil sir,
Thank you.
this some of my patients taking this quinolones, levofloxacin and all, they will get photosensitive early. Whether there is any treatment for photosensitivity?
No, sir. Photosensitivity is a risk factor. We don't have, like we don't even advise the sun shields or the calamine lotions for them. It is an ADR, so it we either if it is troublesome, then we will have to rework on the strategy to drop quinolones and restart some other drug.
And you have given a very good suggestion of preventive treatment for contacts. Because some of the medical stores are not giving without X-ray positive or this CBNAT positive test, they will not allow to give for the private practitioners for the contact treatment. What to do in that case, sir?
We
I
have,
want to
sir.
take the TB contacts.
Sir,
Preventive
we
TB
will give,
contacts.
sir. We have all the drugs with us. Sir, you are from Bellary, sir?
I am from Gadag, sir. Gadag.
Gadag, okay.
Gadag.
I can ask my district TB officer, madam is there, Dr. Arundhati. I'll speak to her, sir. We will be, if dispensing the TB preventive therapy drugs also, sir.
And throughout the treatment of TB, pyridoxine is a must, sir.
Sir, it is very good to put the patient on multivitamins. Pyridoxine is a very good drug, sir.
Okay, thank you.
Good evening, Dr.
Sir.
Suriraji,
Thank you. Dr.
Secretary.
Surviraju, please.
Sir, what is your opinion on contact tracing, sir? Because tuberculosis is a contagious disease. What all the steps you are taking in contact tracing of the thing? And second question is, one of the biggest reason why the tuberculosis patients develop resistance is irregular medications. So, because since it is long-term medications, many patients drop taking medications in between. So, what is your advice to prevent irregular medications and multi-drug resistance?
Hamsa, you want to take it or shall I answer?
Yes, sir. Yes, sir. Thank you so much for the opportunity. So first point ಅಂತಂದ್ರೆ ಲೈಕ್ ಚಾಟ್ ಬಾಕ್ಸ್ ಅಲ್ಲಿ ನೋಡ್ತಾ ಇದ್ವಿ ರಿಕರೆಂಟ್ ಟಿಬಿಗೆ ನಮ್ಗೆ ಎಕ್ಸ್ಕ್ಲೂಸಿವ್ ಆಗಿ ಏನೋ ಬೇರೆ ರೆಜಿಮೆನ್ ಇದೆಯಾ ಅಂತ ಅಂದ್ಬಿಟ್ಟು ಒಂದು ಕ್ವೆಶನ್ ಇದೆ. So one thing I want to highlight here is whether it's a recurrent new, irrespective of whatsoever, now the regimen will be, the treatment will be based on the resistant pattern. So what is the resistant pattern, which drug they are resistant to, based on that the treatment will be taken care. So algorithm kuda namge hage hoytu. First MTB idya, rifampicin resistant idya, then if it all it is there, what is the preference of regimen? That's how it goes. If it is there is no resistant pattern identified, then that will be a DSTP. That's how we go. That is one thing to be highlighted. And second thing, the present question, the contact tracing. Yes, absolutely. Tuberculosis being a communicable disease, if the precise meticulous follow-up of the contacts is being followed, definitely we get the source of index. This has been proved with the genetical sequencing of the contacts and the index case as well. So contact tracing plays a very major role. We should not forget what we learned during COVID also. The primary irbodu, secondary irbodu. The similar way, even for the tuberculosis, even now, if the household contacts have been ruled out for the tuberculosis, we still find the cases among them. But the system where we are actually questionable, we can improvise ourselves is, first point is, when I tell contacts, it's not just a household contact. ಬರೀ ಟಿಬಿ ಬಂದು ನಮ್ಮ ಮನೆಯವ್ರಿಗಷ್ಟೇ ಸ್ಪ್ರೆಡ್ ಆಗುತ್ತೆ ಅನ್ನೋದೇನಿಲ್ಲ. ಅದು ಮಾರ್ಕೆಟ್ ಅಲ್ಲಾದ್ರೂ ಇರ್ಬೋದು, ಬಟ್ ಅಂಡ್ ಇವನ್ ದ ವರ್ಕ್ ಪ್ಲೇಸ್ ಅಲ್ಲಾದ್ರೂ ಇರ್ಬೋದು. ಅಂಡ್ ಇನ್ಫ್ಯಾಕ್ಟ್ ವಿ ಆಲ್ ಬೀಯಿಂಗ್ ಅ ವರ್ಕ್, one or the other way being working in the different work zones, definitely if there is a TB patients, that will be in a workplace as well. The contact can be in workplace, which is very difficult to identify. That is where we are actually the major gap antane highlight ಮಾಡಬಹುದು.
Hello, madam.
Yes, sir. Yes, sir.
What is your opinion regarding ADA test?
Regarding?
ADA test.
ADA use ಮಾಡ್ತೀವಿ sir. Yes, sir. ADA is a good test, especially for fluids, pleural fluid. Anything more than 40 suggests TB. Sir, pleural fluid, we go ahead with clinical diagnosis, cell count, cell type, proteins, ADA. These are the ones that guide us for treating somebody with TB. Because madam ಹೇಳ್ದಂಗೆ 28% ಇದೆ pleural fluid positivity rate. But pleural biopsy ಮಾಡಬೇಕಾಗತ್ತೆ because you know that pleural fluid is reactionary in nature. Actually, the disease is at the pleura. Uh, it is a pleurisy. So the inflammatory fluid ನಾವು ಕಲೆಕ್ಟ್ ಮಾಡಿ fluid ತಗೊಂಡು ಸೆಂಟ್ರಿಫ್ಯೂಸ್ ಮಾಡಿ 5 ml ನಮ್ಗೆ ಕೊಟ್ರೆ ಒಂದು 10% yield ಹೆಚ್ಚಿಗೆ ಆಗ್ಬೋದು ಅಷ್ಟೇ.
Can it be used in ascitic fluid or any other fluids, sir?
Sir, it can be used in ascitic fluid also, but large trials are done only on pleural fluid, and the value of ADA stands tall with the pleural fluid, sir.
Okay, sir. Thank you. Thank you, sir. Thank you.
Thank you.
Sir, I have a last question, sir. Sir, in case of tissue biopsy, as you mentioned, for example, ileocecal TB, the specimen has to send to the culture lab. But for the culture to grow and give the results, it takes, as you said, it's 4 weeks. So till that time, what treatment we have to give for the patient? That's number one. Number two, in case of spine TB, say psoas abscess, or so we diagnose based on the MRI report. So how to do confirmatory diagnosis in that case. We don't take any biopsies.
Yeah, but psoas sepsis is easy, sir. Like you give us the tissue fluid, madam will do a culture and give it to you. If it is an abscess, we do CB-net, take a part to the culture also. When I meant like the tissue biopsy, like whenever you are taking the tissue biopsy, the common DD for ileocecal TB is Crohn's. So one portion will go to
Sir, Anil sir.
Network issue. Network slow.
Dr. Hamsa can complete.
will come to.
Sir, Anil sir, there is a network issue from your
MTB.
side.
Based on nature, they are seeing the giant cells there, then go ahead and once the DST comes, report.
No, it is poor. I think it is not there.
Sir, yeah.
Oh, sir, voice break ಆಗ್ತಿದೆ sir ನಿಮ್ದು Anil sir.
ನಂದು network ಹೋಯ್ತು.
Okay,
Yeah.
okay.
We can hear you now.
Yeah. If the patient is having EPTB or a spine TB, if you are able to reach, take a biopsy. Why I told give it to the culture is because already the sample is split into two. One will go for histopathology, the other will go for microbiology. The third sample will go for TB diagnosis. So, 1/3 of the sample, the yield will always be challenging if I use it or not, and then think of. So we put it for culture, grow the sample, and then give you the result. Based on the histopathology report, says that this is not looking like Crohn's, then you can go ahead and treat it as TB. And once the culture report comes, then you can go based on the DST report, you can treat it as TB. If it comes as Crohn's, then treat it as Crohn's. Similarly, for the MRI images also, if somebody has done a CT guided biopsy, then it comes as granulomatous lesion, then go ahead and treat it as drug susceptible TB initially, because the primary drug resistance in Karnataka still today is around less than 2.5%. So when 98% of the TB patients are drug susceptible, so we can go ahead and treat them as drug susceptible TB. And once the DST results come, we can change the regimen.
Sir,
Thank
sir,
you.
one question, sir. Sir, I am Dr. Narayan Murthy, sir, Director, Varsity Diagnostic Laboratory, Chitradurga, sir. Sir, is it audible, sir?
Yes,
Madam?
sir.
Yeah, we can hear you, Narayan.
Sir, sir, regularly we take CBNAT sample for FNAC of lymph node suspecting tuberculosis. Sir, we are getting one positive in 10 cases. So
Sir,
is it
no,
matching
no,
with
sir.
the
No,
sir?
it is not matching, sir. Sir,
Yes, sir.
what happens is, sir, you'll before taking the biopsy, you please speak to the surgeon, sir, because they should take the biopsy from the disease site.
Sir,
Lymph
FNAC, sir.
node, FNAC, sir, yield will always be lesser, sir.
Less.
Sir, FNAC, it is always lesser compared to biopsies. Biopsies are
Okay.
preferred, sir,
Yes, sir. Yes, sir. Sir,
because yes.
and second question is, we do CBNAT for synovial fluid, CSF, and ascitic also. Is it wise doing CBNAT sample along with the ADA?
Yeah, obviously, sir. ADA is
Complementary.
different. It complements, sir. Sir,
Yes, sir.
ADA should be read with other parameters like what I told: proteins, sugars,
Okay, sir. Yes,
your
yes, sir.
cell count, cell type.
Microscopy, cell count, cell type. Yes, sir.
Yes, sir. Not with CBNAT.
Okay,
So,
sir.
so you will have to read it along with on those lines and the patient's clinical profile. Whereas CBNAT, irrespective of the patient's clinical profile, if like what I think Nirmala madam told us, or Hamsa told us, incipient TB or subclinical TB. So, the patient may not throw symptoms, but X-ray may be showing some vague shadows. You
Yes,
collect a
sir.
good
Yes, sir.
sample, CBNAT comes positive. So,
Yes, sir.
irrespective of the patient's clinical profile, CBNAT will give you the result.
Yes, sir. Yes, sir. Yes,
Sir,
sir.
what
Thanks,
is
sir.
the role? Sir, what is the role of IGRA when it comes to starting the preventive therapy?
It is, ma'am, I told you, in fact, IGRA stands as the test for looking at TB infection. So, if somebody is IGRA positive and he has X-ray is clear, he is asymptomatic, goes to show that and he falls in the vulnerable group, then it is always wise that he started on TB preventive therapy. The chances of somebody who is having a TB infection progressing to TB disease is maximum in the first 2 years. So, it is good that we treat him with TB preventive therapy so that we can prevent TB disease in them.
Sir, if IGRA comes as indeterminate, so should we repeat the test or
Obviously, yes.
after, like, is there a time duration after which
No,
we can?
immediately. Like indeterminate does not come. Usually you get invalids because of the error in transportation or bleeding. IGRA is a beautiful test. You cannot take a second bite in IGRA if you are by taking a IV sample. It should be with one prick only, and the sample should be exactly 5 ml, and it should be transported within 24 hours to the lab, and the lab should start processing the sample immediately. Once you segregate the plasma, then you can keep it. So if there is any delay or anything that is a lapse in these processes, you will get invalid results.
Okay, sir. So even if the patient is asymptomatic and no chest abnormalities, just because IGRA has come positive, we have to start on preventive therapy.
That is what, like they are not patients. They are people like me and you.
Yes, sir.
So patients are TB with the disease.
Yes, sir.
These are infection, like if you do IGRA on me, it will be positive. I hope you will also be positive on IGRA.
So the preventive has to be started once it comes positive.
Yeah.
Okay. Thank you, sir. Thank you.
Any queries?
Yes, sir. Dr. Satish here from Bidar, sir.
ಸತೀಶ್ ನಮಸ್ತೆ, ನೀವ್ ಜಾಯ್ನ್
ನಮಸ್ತೆ
ಆಗಿದ್ದೀರಾ?
ಸರ್ ಅದೇ ಮಾತಾಡ್ತಿದ್ದೆ. ಅದು ಏನಾಗುತ್ತೆ ಸರ್, ಒಂದು ಕಾಂಪ್ಲಿಕೇಶನ್ ಎಲ್ಲಾಗುತ್ತೆ ಅಂದ್ರೆ ಈ ಪ್ರಿವೆಂಟಿವ್ ಥೆರಪಿಲಿ ಇಫ್ ದಿ ಪೇಷಂಟ್ ಇಸ್ ಆಲ್ರೆಡಿ ಟ್ರೀಟೆಡ್ ನಾವು ಸಿಂಪ್ಟಮ್ಯಾಟಿಕ್ ಅಂಡ್ ಇಗ್ರಾ ಮೇಲೆ ನಾವು ಸ್ಟಾರ್ಟ್ ಮಾಡ್ಬೇಕು ಪ್ರಿವೆಂಟಿವ್ ಅಂದಾಗ ಸ್ವಲ್ಪ ಕಾಂಪ್ಲಿಕೇಟ್
ಇಲ್ಲ,
ಆಗುತ್ತೆ
ಈಗ
ಸರ್.
ಈಗ ಪೇಷಂಟ್ ಆಲ್ರೆಡಿ ಕ್ಯೂರ್ಡ್, asymptomatic, only if is HIV we are giving them TB preventive therapy. To the other groups we are not giving.
ಎಸ್ ಸರ್. ಇನ್ನೊಂದೇನಾಗಿದೆ ಸರ್, ನಿರ್ಮಲಾ ಮ್ಯಾಮ್ ಹೇಳಿದ್ರಲ್ಲಿ ಲಾಸ್ಟ್ ಇಯರ್ ಕೇಳಿಸ್ತಿದೆಯಾ ಸರ್?
ಈಗ ಬ್ರೇಕ್ ಆಯ್ತು ನಿಮ್ಮ ವಾಯ್ಸ್.
ಹಾ ಸರ್, ದಿ ಸೆನ್ಸಿಟಿವಿಟಿ ಆಫ್ ಸಿಬಿನಟ್ ಇನ್ ಪ್ಲೂರಲ್ ಫ್ಲೂಯಿಡ್ ಸರ್, ಅದರಲ್ಲಿ ಏನಾಗಿದೆ, ಪ್ರೈಮರಿ ಫಸ್ಟ್ ಟೈಮ್ ಇದರಲ್ಲೇ ಒಂದೇ 9 months ಪೀರಿಯಡ್ ಅಲ್ಲಿ, ಲಾಸ್ಟ್ ಇಯರ್ ಅಲ್ಲಿ 2024 ಅಲ್ಲಿ 9 months ಪೀರಿಯಡ್ ಅಲ್ಲಿ 3 ಪ್ಲೂರಲ್ ಟ್ಯಾಪಿಂಗ್ ಮಾಡಿದ್ದು 3 ಪ್ರೈಮರಿ MDR ಬಂತು ಸರ್ ನನ್ನ ಹತ್ರ. ಐ ಥಿಂಕ್ ದಟ್ ವಾಸ್ ಫಸ್ಟ್ ಇನ್ ಕರ್ನಾಟಕ ನಾನು ಮಾಡಿದ್ರಲ್ಲಿ.
ಓಕೆ.
3 ಕೇಸಲ್ಲಿ ಏನಾಯ್ತು, ಅದ್ರಲ್ಲಿ ಒಂದು ಕೇಸ್ ಹೆಲ್ತ್ ಕೇರ್ ವರ್ಕರ್ಸ್. ದಿ ಸೆಕೆಂಡ್ ಪರ್ಸನ್ ವಾಸ್ ಅ ಹೆಲ್ತ್ ಕೇರ್ ವರ್ಕರ್ ಅಂಡ್ ಹಿ ಯೂಸ್ ಟು ಆಬ್ವಿಯಸ್ಲಿ ಒಂದು ವಿಸಿಟ್ ಒನ್ಸ್ ಇನ್ ಅ ವೈಲ್ ಟು ಚೆಸ್ಟ್ OPD, ನನ್ನ OPDಗೆ. ಅವನಿಗೆ ನಾವು ಕೊಟ್ಟ ಮೇಲೆ ಇಟ್ ವಾಸ್ ವೆರಿ ಅನ್ಫಾರ್ಚುನೇಟ್ ಬಿಕಾಸ್ ಹಿ ಹ್ಯಾಡ್ ಟೇಕನ್ DSTB ಫಾರ್ 6 months ಫ್ರಮ್ ಪ್ರೈವೇಟ್ ಹೈದರಾಬಾದ್ ಇಂದ. ವೆನ್ ಐ ಡಿಡ್ ಅ ಪ್ಲೂರಲ್ ಟ್ಯಾಪಿಂಗ್ ಆಫ್ಟರ್ 6 months ಆಫ್ ATT, ಆವಾಗ MDR ಬಂತು ನಮ್ಮ ಹತ್ರ ಗೌರ್ಮೆಂಟ್ ಅಲ್ಲಿ. ದೆನ್ ವಿ ಸ್ಟಾರ್ಟೆಡ್ ಆನ್ ಅಪ್ರೋಪ್ರಿಯೇಟ್ DRT ರೆಜಿಮೆನ್. ಬಟ್ ದಿ ಪರ್ಸನ್ ಸಫರ್ಡ್, ಎಷ್ಟು ಸಫರ್ ಆಯ್ತು ಅವನಿಗೆ ಅಂದ್ರೆ ಪೆರಿಫೆರಲ್ ನ್ಯೂರೋಪತಿ, ಇದು ಏನ್ ಕೊಟ್ಟರು ಕಡಿಮೆ ಆಗ್ಲಿಲ್ಲ. ಪ್ರಾಬ್ಲಿ ಹಿ ಹ್ಯಾಸ್ ಸಫರ್ಡ್ ಪರ್ಮನೆಂಟ್ ಪೆರಿಫೆರಲ್ ನ್ಯೂರಲ್ ಡ್ಯಾಮೇಜ್ ಅಂಡ್ ಎಲ್ಲ ಕೊಟ್ವಿ. ನೌ ಹಿ ಹ್ಯಾಸ್ ಸ್ಟಾಪ್ಡ್ ಕಮಿಂಗ್ ಟು ವರ್ಕ್. ಸೊ ದಟ್ ವಾಸ್ ವೆರಿ ಅನ್ಫಾರ್ಚುನೇಟ್.
ಸರ್, ನಮ್ಗೆ TB, ನಾನು ಎಲ್ಲ ನಮ್ಮ ಡಾಕ್ಟರ್ ಕೊಲೀಗ್ಸ್ಗೆ ನಾನು ರಿಕ್ವೆಸ್ಟ್ ಮಾಡ್ಕೊಳ್ಳೋದು ಅದೇ, ದ ಫಸ್ಟ್ ಟೈಮ್ ಇಸ್ ದ ಬೆಸ್ಟ್ ಟೈಮ್ ಟು ಟ್ರೀಟ್ TB ಪೇಷಂಟ್ಸ್. ಅನ್ಫಾರ್ಚುನೇಟ್ಲಿ ಫಾರ್ ವಾಟ್ ಎವರ್ ರೀಸನ್ಸ್ ವಿ ಫೇಲ್ ಅಲ್ವಾ, ಆಲ್ ದ ಸೆಕೆಂಡ್ ಲೈನ್ ಡ್ರಗ್ಸ್ ರೆಕ್ ಹ್ಯಾವಕ್ ಆನ್ ಅಸ್. ಯಾರಾದ್ರೂ ಇಲ್ಲಿ ಒಂದ್ ವಾರ ಲಿನೋಸಿಲಿಡ್ ತಗೊಂಡಿದಾರ ಅಂತ?
ಹೌದು ಸರ್, ಬಹಳ ಕಷ್ಟ.
ನಮ್ಮ ತಂದೆಗೆ, ಅವ್ರಿಗೆ ಸ್ಟಾಫ್ ಸೆನ್ಸಿಟಿವ್ ಓನ್ಲಿ ಟು ಲಿನೋಸಿಲಿಡ್ ಬಂತು. ಅವ್ರಿಗೆ ನಾನು ಲಿನೋಸಿಲಿಡ್ ಕೊಟ್ಟಾಗ, ನೀನ್ ಯಾವನ್ ಡಾಕ್ಟರ್ ಅಂತ ಅನ್ಲೇ, ನೀನು ನೀನ್ ಕೊಲೆ ಗುಡ್ಕ, ನೀನ್ ಡಾಕ್ಟರ್ ಅಲ್ಲ ಅಂತ
ತುಂಬಾ ಟಾಕ್ಸಿಕ್ ಡ್ರಗ್ಸ್ ಸರ್. ನಮ್ ಡ್ರಗ್ಸ್ ತುಂಬಾ ಟಾಕ್ಸಿಕ್ ಇರ್ತವೆ ಸರ್.
we asked them to take for so long.
For 6 months, 9 months, ಅದು ತುಂಬಾ ಕಷ್ಟ ಆಗುತ್ತೆ ಸರ್. ಇನ್ನೊಂದು ಕ್ವಶನ್ ಇದೆ ಸರ್, ದಿಸ್ ಓನ್ಲಿ ಆಫ್ ಅಕಾಡೆಮಿಕ್ ಇಂಟ್ರೆಸ್ಟ್. ವೈ ಸಮ್ ಪೀಪಲ್, ಅಂದ್ರೆ ಕೆಲವು ಜನಕ್ಕೆ ಮಾತ್ರ ದೇ ಡೆವಲಪ್ ದಿ ಡಿಸೀಸ್, ವೆದರ್ ಎನಿ ಸ್ಟಡಿ ವಾಸ್, ಯಾಕಂದ್ರೆ ನೀವು ತುಂಬಾ ವರ್ಷದಿಂದ ಇದನ್ನ ನೋಡಿದಿರಿ, ವೆದರ್ ಎನಿ ಸ್ಟಡಿ, ಸಿಸ್ಟಮ್ಯಾಟಿಕ್ ಸ್ಟಡಿ ವಾಸ್ ಡನ್, ವೈ ಸಮ್ ಪೀಪಲ್ ವಿತ್ ಎ ಪರ್ಟಿಕ್ಯುಲರ್ ಬ್ಲಡ್ ಗ್ರೂಪ್ ನೆವರ್ ಡೆವಲಪ್ ದ ಡಿಸೀಸ್ ದೋ ಬೀಯಿಂಗ್ ದಿ ಇನ್ ದ ಸೇಮ್ ರಿಸರ್ವೈರ್ ಆಫ್ ಪಾಪ್ಯುಲೇಷನ್.
ನಾನು ಇದ್ರ ಬಗ್ಗೆ ಕೇಳಿದೀನಿ, ಬಟ್ ಸ್ಟಡಿ ಅಂತೂ ಮಾಡಿಲ್ಲ.
ಅದು ಮಾಡಬೇಕು ಸರ್. ನಾವು ಹೆಲ್ತ್ ಕೇರ್ ವರ್ಕರ್ಸ್, ನಾವು ಯಾವಾಗ್ಲೂ OPD ಇದ್ದು ಕೂಡ ವಿ ಹ್ಯಾವ್ ನೆವರ್ ಬಿನ್ ಇನ್ಫೆಕ್ಟೆಡ್. ಅದು ಯಾಕಾಗುತ್ತೆ ಆ ತರ? ವೈ ಸಮ್ ಪೀಪಲ್ ದೋ ದೇ ಆರ್ ಒಕೇಶನಲಿ ಎಕ್ಸ್ಪೋಸ್, ದೇ ಸಡನ್ಲಿ ಕ್ಯಾಚ್ ದ ಇನ್ಫೆಕ್ಷನ್ ಅಂಡ್ ಬಿಕಮ್ ಪೇಷಂಟ್. ಸ್ವಲ್ಪ ಅದನ್ನ ನೋಡಿ ಸರ್, ಇಫ್ ಇಟ್ ಕ್ಯಾನ್ ಬಿ ಎನ್ಕರೇಜ್ ಅವೇರ್. ಥ್ಯಾಂಕ್ ಯು ಸರ್.
ಅದೇ, ಇಟ್ ಗೆಟಿಂಗ್ 2 hours now. Really very interesting. And I think when we start talking tuberculosis, it never ends, because there's so much of things to learn from these learned people. Anil, I think, is encyclopedia, Hamsaveni, and Dr. Nirmala, and many more people are there on the field who can just definitely impart so much of knowledge to us. So many things to learn from them. ಅದಕ್ಕೆ ಸರ್, ಕೇಳಿಸ್ತಾ ಇದೆಯಾ?
Please share their contact number, sir.
ಒಂದ್ ನಿಮಿಷ
share their contact number, sir.
ಮಾತಾಡ್ತೀನಿ, ಒಂದ ನಿಮಿಷ ಸರ್. ಅನಿಲ್ ಸರ್, can you hear me?
Yes, sir.
Yeah, I think March month is the best month, I feel, because Women Doctors Day, Women's Day we celebrated. Most of the DTOs, and ಇವತ್ತು ಹಂಸವೇಣಿ ಮತ್ತು ನಿರ್ಮಲಾ ಮೇಡಮ್ ಅವರು, ನಮ್ಮ DTO ಕೂಡ ಡಾಕ್ಟರ್ ಇಂದ್ರಾಣಿ, ಆಲ್ಮೋಸ್ಟ್ ಮೋಸ್ಟ್ ಆಫ್ ದೆಮ್ ಆರ್ ಡೂಯಿಂಗ್ ಸೋ ಮಚ್ ಆಫ್ ವರ್ಕ್ ಫಾರ್ tuberculosis.
ಸರ್, ಇಂದ್ರಾಣಿ ಮೇಡಮ್ ಜಾಯಿನ್ ಆಗಿದಾರಾ?
Yeah, she was there. I spoke to her.
DTO Ballari is there.
Okay.
Yeah, we had a very unique program at Taluka place. I think we can implement across Karnataka, where we have involved the local private lab technicians. ದೇವರ್ ಅಲ್ಲಿ ಹೋಗಿ ಪ್ರಾತ್ಯಕ್ಷಿಕವಾಗಿ ಸಿಬಿನೆಟ್ ಹ್ಯಾಗ್ ಮಾಡ್ತಾರೆ ಅಂತ ಹೇಳ್ಬಿಟ್ಟು ಸುಮಾರು 1 ಅವರ್ ಇಂದ್ರಾಣಿ ಮೇಡಮ್ ತೋರಿಸಿದ್ರು ಅವ್ರಿಗೆ. ಬಿಕಾಸ್ ಇವೆಲ್ಲವೂ ಗವರ್ಮೆಂಟ್ ಸೆಟಪ್ ಅಲ್ಲಿ ಆಗ್ತಿದ್ದಾಗ ಪ್ರೈವೇಟ್ ಅಲ್ಲಿ ಇರ್ತಕ್ಕಂಥವ್ರು ಸ್ವಲ್ಪ ಕತ್ಲಲ್ಲಿ ಇರ್ತಾರೆ. ಅವ್ರಿಗೂ ಸಹ ಒಂದಷ್ಟು ನಾಲೆಡ್ಜ್ ಬರಲಿ ಅಂತ ಹೇಳಿ ದಟ್ ವಾಸ್ ಅ ಯುನೀಕ್ ಪ್ರೋಗ್ರಾಮ್ ದಟ್ ವಿ ಹ್ಯಾಡ್. ಅಂಡ್ IMA ಹಾನರ್ಡ್ ಈ ಟ್ಯೂಬರ್ಕ್ಯುಲೋಸಿಸ್ ಅಲ್ಲಿ ಕೆಲಸ ಮಾಡ್ತಕ್ಕಂಥ ಸರ್ಕಾರದ ಎಲ್ಲ ಲ್ಯಾಬ್ ಟೆಕ್ನಿಷಿಯನ್ಸ್ ಅನ್ನ ನಾವು ಸನ್ಮಾನ ಮಾಡಿದ್ವಿ. ಬಿಕಾಸ್ ದೇ ಆರ್ ಡೂಯಿಂಗ್ ಲಾಟ್ ಆಫ್ ಗ್ರೌಂಡ್ ವರ್ಕ್. ಇಲ್ಲಿ ಒಂದು ಪಾರ್ಟ್ ನಾವು ಇವತ್ತು ಡಿಸ್ಕಸ್ ಮಾಡಿದ್ದು ಅಕಾಡೆಮಿಕ್ ಆಕ್ಟಿವಿಟೀಸ್, ಅಕಾಡೆಮಿಕ್ ಪಾರ್ಟ್ ಆಫ್ ದಿ ಟ್ಯೂಬರ್ಕ್ಯುಲೋಸಿಸ್. ಬಟ್ ದೆರ್ ಇಸ್ ಒನ್ ಮೋರ್ ಪಾರ್ಟ್ ವೇರ್ ಆಲ್ ದೀಸ್ ಮೆಡಿಕೇಶನ್ಸ್, ಡ್ರಗ್ಸ್, ನೀವು ಮಾತಾಡಿದ್ರಿ ಸರ್ ಅನಿಲ್ ಸರ್, ಇವೆಲ್ಲವೂ ಪೇಷಂಟ್ ಹೊಟ್ಟೆಗೆ ಹೋಗ್ಬೇಕು, ಪೇಷಂಟ್ ದೇಹಕ್ಕೆ ಹೋಗ್ಬೇಕು. ಅದರಲ್ಲಿ then only we succeed in eliminating or controlling the tuberculosis. This is where IMA wants to get involved with these activities, elimination tuberculosis. ಬರೋ ದಿನಗಳಲ್ಲಿ ಬಹುಶಃ I think Dr. Chinevalar will agree with me, being leaders of IMA, we want to be associated with elimination tuberculosis at the grassroots level. ಬಿಕಾಸ್ ಇವತ್ತೆಲ್ಲವೂ ನಾವು ಅಕಾಡೆಮಿಕ್ ಆಗಿ ಮಾತಾಡಿದ್ವಿ ಇದ್ರ ಎಲ್ಲದ್ರ ಬಗ್ಗೆ. ವೇರ್ ದಿ ಪ್ರೈವೇಟ್ ಪ್ರಾಕ್ಟೀಷನರ್ಸ್, ದಿ IMA, ವಿ ಹ್ಯಾವ್ 180 ಬ್ರಾಂಚಸ್ ಅಕ್ರಾಸ್ to where do we help you out in implement these programs?
Sir, ನನಗೆ as far as Ballari is I consider you have one of the best DHOs and one of the best DTOs. You will have no problem in engaging with them. They will be all out supporting you. ನಮ್ಗೇನಾಗುತ್ತೆ, ಬ್ಯಾಂಗ್ಳೂರ್ ಅಂತ ಜಾಗದಲ್ಲಿ ಸ್ವಲ್ಪ ಚಾಲೆಂಜ್ ಬರುತ್ತೆ ಬಿಕಾಸ್ BBMP ತುಂಬಾ ದೊಡ್ಡದಿದೆ. ಅದರ್ ದನ್ ದಟ್ ನನಗೆ ಪೆರಿಫೆರಿಯಲ್ಲಿ ವಿ ವಿಲ್ ನಾಟ್ ಹ್ಯಾವ್ ಮೈಸೂರು ಇರ್ಬೋದು, ಹುಬ್ಳಿ ಧಾರವಾಡ ಇರ್ಬೋದು. ಸೊ ಇಲ್ಲಿ ನಮಗೆ ಬೇರೆ ಪ್ಲೇಸಸ್, ಅದರ್ ಪ್ಲೇಸಸ್ ವಿ ವಿಲ್ ಸಿಟ್ ವಿತ್ ಯು ಪೀಪಲ್ ಸರ್. ವಿ ಕ್ಯಾನ್ ಹ್ಯಾವ್ ಒನ್ ರೋಡ್ ಮ್ಯಾಪ್ ತರ ಮಾಡಿಬಿಟ್ಟು ವಿ ಕ್ಯಾನ್ ಡಿಸೆಮಿನೇಟ್ ಇಟ್ ವಿತ್ ನಮ್ಮ ಫೀಲ್ಡ್ ಸ್ಟಾಫ್ಗೆ, ನಮ್ಮ ಡಿಸ್ಟ್ರಿಕ್ಟ್ TB ಆಫೀಸರ್ಸ್ಗೂ ಕೊಡ್ಬೋದು. So this is what we have to do. This is what IMA will support us. So your support will be of immense help to TB program. There is no second thought on that. So if IMA joins hands, now in 2030 ಅನ್ಕೊಂಡಿದ್ವಿ, we can be much more ahead of 2030 in reducing the TB burden at least. ಸರ್, ನಮ್ಮಲ್ಲಿ ಏನಾಗ್ತದೆ, ಇಫ್ ಐ ಲುಕ್ ಅಟ್ ಕರ್ನಾಟಕ ಆಸ್ ಎ ಹೋಲ್, ದ ಕಲ್ಯಾಣ ಕರ್ನಾಟಕ ಏರಿಯಾ ಏನಿದೆ, ದೇರ್ ಇಸ್ ಅ ಬಿಗ್ ನಂಬರ್ ಆಫ್ TB ಪೇಷಂಟ್ಸ್ ದೇರ್. ಸೊ ಅಲ್ಲಿ ಸ್ವಲ್ಪ ಆಕ್ಟಿವ್ ಆಗಿ IMA ನಮ್ಮ TB ಪ್ರೋಗ್ರಾಮಿಗೆ ಸಪೋರ್ಟ್ ಮಾಡಿದ್ರೆ, ಈಗ ಎಲ್ಲ ಕಡೆ CBNet ಇದೆ, TrueNet ಇದೆ, ನಿಮ್ಮ ಸ್ಯಾಂಪಲ್ಸ್ ನಾವು ಅಷ್ಟು ಫ್ರೀ ಮಾಡ್ಕೊಡ್ತೀವಿ. ನಿಮ್ಗೆ ಏನ್ ಡ್ರಗ್ಸ್ ಬೇಕು ಅದು ಫ್ರೀ ಕೊಡ್ತೀವಿ. ಸೊ we can be on the same page, sir. We are there to support you are here to support the TB program. Andre, each patient of the IMA will be supported by TB program, and you need not refer TB patients to TB program, sir. Idu nim patient ನೀವೇ ಟ್ರೀಟ್ ಮಾಡ್ಬೇಕು, sir. They will come to you.
Sure, sir.
So we will not.
ಸ್ವಲ್ಪ ಉತ್ತರ ಕರ್ನಾಟಕದ ಬಗ್ಗೆ ಗಮನ ಇರಲಿ ಸರ್, ಬಿಕಾಸ್ ಯುವರ್ ಆಲ್ ಸ್ಟೇಟ್ ಟ್ಯೂಬರ್ಕ್ಯುಲೋಸಿಸ್ ಆಫೀಸರ್ಸ್, ಪಾಪ್ಯುಲೇಷನ್ ಬೇಸ್ಡ್ ಅಂದ್ರೆ ಸಿ ದಿ ಹ್ಯಾಬಿಟ್ ಚೇಂಜಸ್ ಫ್ರಮ್ ಸೌತ್ ಕರ್ನಾಟಕ ಟು ನಾರ್ತ್ ಕರ್ನಾಟಕ. ಇಲ್ಲೆಲ್ಲ ಉಗಿಯೋದು, ಆಮೇಲೆ ಓರಲ್ ಹೈಜಿನ್ ತುಂಬಾ ಕಡಿಮೆ ಇರ್ತದೆ. ಅಂಡ್ ರಿಸೋರ್ಸಸ್ ಅಂಡ್ ಮೆಷಿನರೀಸ್, ಎವ್ರಿಥಿಂಗ್ ಶುಡ್ ಬಿ ಆನ್ ಎ ಲಾರ್ಜರ್ ಸ್ಕೇಲ್ ಅಲ್ಲಿ ನಮ್ಗೆ ಕೊಡ್ಬೇಕಾಗುತ್ತೆ. ಬಿಕಾಸ್ ಬರ್ಡನ್ ಇಸ್ ಮೋರ್, population is more, education is less, poverty is more. So considering all these things, ತಾಲೂಕಾ ಲೆವೆಲ್ ಈಗೆಲ್ಲ ಬಂದಿದೆ ಸರ್. ಬಟ್ ಹ್ಯಾಂಡ್ ಹೆಲ್ಡ್ ಎಕ್ಸ್ರೇ ಮಷಿನ್ಗಳದ್ದು ತುಂಬಾ ಸಪ್ಲೈ ಕಡಿಮೆ ಇದೆ ಅಂತ ಕೇಳಿದ್ದೀನಿ ಈ ಕಡೆಗೆಲ್ಲ. ಸೊ
ಕರ್ನಾಟಕದಲ್ಲಿ 10 ಏನಾದ್ರ ಬಂದ್ರೆ 7 ಕಲ್ಯಾಣ ಕರ್ನಾಟಕಕ್ಕೆ ಹೋಗುತ್ತೆ, 3 ಸೌತ್ಗೆ ಬರೋದು.
ಅನಿಲ್ ಸರ್, ಗದಗ ಡಿಸ್ಟ್ರಿಕ್ಟ್ ನ ಸ್ವಲ್ಪ ಪ್ರೈವೇಟ್ ಪ್ರಾಕ್ಟೀಷನರ್ಗೆ TB ಟ್ರೀಟ್ಮೆಂಟ್ ದೇ ಆರ್ ವೆರಿ ಮಚ್ ಇಂಟ್ರೆಸ್ಟೆಡ್. ಆಲ್ ಪ್ರೈವೇಟ್ ಪ್ರಾಕ್ಟೀಷನರ್ಸ್ ಅವ್ರಿಗೆ ಸ್ವಲ್ಪ TB ಆಫೀಸರ್ಸ್ಗೆ ಸ್ವಲ್ಪ ಡ್ರಗ್ಸ್ ಸಪ್ಲೈ ಮಾಡಕ್ ಹೇಳ್ರಿ.
ಸರ್, ಕೊಡಿಸ್ತೀನಿ ಸರ್.
Gadag district.
Yes, sir. Yes, sir.
Yes,
Yes,
sir.
sir.
Thank you very much, sir.
Thank you.
Chinwal sir,
Thank you,
anything
sir.
to add? It's already 2 hours now. We can have definitely, sir, kindly prepare a roadmap for IMA and STO.
Yes, sir.
It cannot be end with this webinar. This is my vision
Yes.
and our IMA vision. Let us not end with this webinar because we have learned so many things. ಇಷ್ಟು ಸಮಯದಲ್ಲಿ ಕಡಿಮೆ ಸಮಯದಲ್ಲಿ ತುಂಬಾ ಕಲಿಯೋದು ಕಷ್ಟ ಆಗುತ್ತೆ ಸರ್. ಸೊ ಇಟ್ ಶುಡ್ ಬಿ ಅ ಕಂಟಿನ್ಯೂಸ್ ಪ್ರಾಸೆಸ್ ವಾಟ್ ಐ ಫೀಲ್. ಅಂಡ್ ಲಾಂಗ್ ರನ್ ಅಲ್ಲಿ ಇದು ಆಗ್ಲೇಬೇಕಾಗುತ್ತೆ. ಡಿಸ್ಟ್ರಿಕ್ಟ್ ಆಮೇಲೆ ತಾಲೂಕನ್ನ ನಾವು ಕವರ್ ಮಾಡೋದಕ್ಕೆ IMA ಇಸ್ ವೆರಿ ರೋಬಸ್ಟ್ ನೌ. ವಿ ಹ್ಯಾವ್ ಸೋ ಮೆನಿ ಲೀಡರ್ಸ್ ಅಕ್ರಾಸ್ ಕರ್ನಾಟಕ. ಡಾಕ್ಟರ್ ಚಿನಿವಾಲರ್ ಇದ್ದಾರೆ, ಸೂರ್ಯರಾಜು ಬೆಂಗಳೂರು ಕಡೆಗಿದ್ದಾರೆ, ಯೋಗಾನಂದ ರೆಡ್ಡಿ, ಹೊನ್ನೇಗೌಡರು, ಡಾಕ್ಟರ್ ಲಕ್ಕೋಳ್. ಸೊ ತುಂಬಾ ಪೆರಿಫೆರಿಯಲ್ಲಿ ರೋಣದಂತ ವೆರಿ ರಿಮೋಟ್ ಪ್ಲೇಸ್, ಬಸ್ಗಳು ಹೋಗಲ್ಲ ಅಂತ ಜಾಗದಲ್ಲೂ ಇದ್ದಾರೆ. ಸೊ ಇವೆಲ್ಲರೂ ನಾವು ಸೇರ್ಕೊಂಡು ಇದನ್ನ ನಿರ್ಮೂಲನೆ ಮಾಡೋದಕ್ಕೆ ಖಂಡಿತ ನಿಮ್ ಜೊತೆಗಿದ್ದೀವಿ. ಆ ನಿಟ್ಟಲ್ಲಿ 1 ವರ್ಷದ ಅವಧಿಯ ಅಥವಾ 2 ವರ್ಷದ ಅವಧಿಯ ಒಂದು ರೋಡ್ ಮ್ಯಾಪ್ ಹಾಕೊಂಡು ಕೊಡಿ ಸರ್. ದೆನ್ ವಿ ವಿಲ್ ಟ್ರೈ ಟು ರೀಚ್ ದ ಟಾರ್ಗೆಟ್ ಅಲಾಂಗ್ ವಿತ್ ಯು.
Okay, sir. Okay.
ಯಾಕಂದ್ರೆ ಲೆಟ್ ಅಸ್ ನಾಟ್ ಎಂಡ್ ವಿತ್ ದಿಸ್. ಸೊ ಎನಿಥಿಂಗ್ ಆಡ್ ಮಾಡಿ, ಇಲ್ಲಾಂದ್ರೆ ವಿ ಕ್ಯಾನ್.
ನಮಸ್ಕಾರ
It is a continuous. It is a continuous education. Continuous.
ಅನಿಲ್ ಅವರೇ,
Throughout the year we will have this
TB
eradication program.
ಡಾಕ್ಟರ್ ಅನಿಲ್ ಅವರೇ, ನಮ್ಮ IMA ಕಡೆಯಿಂದ ನಿಮಗೆ ಪೂರ್ಣ ಪ್ರಮಾಣದ ಸಹಕಾರ ನಾವು ಕೊಡ್ತೀವಿ. ಇದು ಜಸ್ಟ್ ಬಿಗಿನಿಂಗ್. ಇದು ಈಗ ಮಧುಸೂದನ್ ಹೇಳಿದಂಗ ಏನಂತಲ್ಲ, ನಮ್ಮ ಕಲ್ಯಾಣ ಕರ್ನಾಟಕ ಭಾಗಕ್ಕೆ ಆದಷ್ಟು ಏನಂತಲ್ಲ ಒಂದು ಆದ್ಯತೆಯನ್ನು ಕೊಟ್ಟು ಏನಂತಲ್ಲ ಈ ಭಾಗದಲ್ಲಿ ಈ ಟ್ಯೂಬರ್ಕ್ಲೋಸಿಸ್ ಏನಂತಲ್ಲ ರೋಗ ಬಹಳ ಹಬ್ಬಿದೆ. ಇದನ್ನ ಮತ್ತು ಥ್ರೂಔಟ್ ಕರ್ನಾಟಕಕ್ಕೆ ಒಂದು ರೋಡ್ ಮ್ಯಾಪ್ ಹಾಕಿ ನೀವು ಏನಂತಲ್ಲ ಮಾಡಿದಪ್ಪ ಅಂದ್ರೆ ಎಲ್ಲ ನಮ್ಮ IMA ಶಾಖೆಗಳ ಮುಖಾಂತರ ನಿಮಗೆ ಪೂರ್ಣ ಪ್ರಮಾಣದ ಸಹಕಾರ ಕೊಡ್ತೀವಿ ಅಂತ ಹೇಳಿ ನಾನು ಏನಂತಲ್ಲ ನಮ್ಮ ರಾಜ್ಯ ಶಾಖೆಯ ಪರವಾಗಿ ತಮಗೆ ಒಂದು ತಿಳಿಸ್ತಾ ಇದ್ದೀನಿ.
ಆಮೇಲೆ ಕಲ್ಯಾಣ ಕರ್ನಾಟಕ ಸ್ವಲ್ಪ ಇನ್ಸಿಡೆನ್ಸ್ ಆಫ್ TB is also more, sir.
ಹೌದು ಸರ್, ಅದಕ್ಕೆ
Because I am getting patients from Koppal district. There are a lot of compared to Gadag district, ಕಲ್ಯಾಣ ಕರ್ನಾಟಕ ಸ್ವಲ್ಪ ಜಾಸ್ತಿ ಇದಾವೆ ಸರ್ ಇನ್ಸಿಡೆನ್ಸ್, TB ಇನ್ಸಿಡೆನ್ಸ್.
Yes, sir. ಹೌದು ಸರ್.
Yes, sir. Yes, sir. Thank you, sir. Padma, are you on line?
I'm here, sir.
Yeah, I request, sir, shall we end? Hello.
Okay.
Yeah, shall we close?
Hello, Madhusudan.
Yeah, it's really good that 2 ಗಂಟೆ ಆದ್ರೂ we have 35 audience in the group. I think we will carry forward our work along with the government officials and government programs. And here is Dr. Padma Prakash, who is a pediatrician from Bangalore, and she is the chairman of IMA MSN Karnataka State Branch. I request her to render a vote of thanks. Padma, over to you.
Yes, sir. Thank you so much, sir. Good evening, everyone. As we conclude this session on the International Tuberculosis Day, where we came with the commit, invest, deliver. Yes, we can end tuberculosis. Such a wonderful program. I am honored to deliver vote of thanks on behalf of IMA KSB. So I express my sincere gratitude to the speakers, Dr. Anil sir, Joint Director of State Tuberculosis Officer, NTEP Karnataka, Dr. Nirmala ma'am, Senior Specialist, State Tuberculosis Center, Bengaluru, Dr. Hamsaveni, WHO National Consultant, DRTB, Central TB Division, New Delhi, and the moderator of the day, Dr. Madhusudan sir. He is a member, IMA Headquarters, NTB Initiative, as well as the past president of IMA KSP. Such a wonderful moderation and such a wonderful discussion as well. As sir was mentioning that even it's, I think, 11:20 now, but still at the end discussion was truly very clinical it was. So again, I render my vote of thanks to Dr. Chiniwala sir for his presence here, Dr. Suriraju, Honorary Secretary IMA KSP, Dr. Pavan Kumar, Chairman IMA JDN, Dr. Narayan Murthy, IMA KSP is the Chairman of Academic Cell, and all the senior doctors, Vice President Headquarters, Dr. Bidinar sir, to all the seniors who are present, Dr. Shankar Narayan sir is Secretary of IMA KSP, Dr. Anuradha Parmesh ma'am, Nizamuddin, Jaspal Singh, Vijay Kumar sir, Dr. Sarvesh, and all the senior doctors who took time out of your busy schedules and participated in the event. I think hope to see you all of you in the coming days to end tuberculosis. As all the seniors were saying, it's a high time that we have to take initiative and do it. Once again, thank you very much. Thanks, everyone.
Thank you, Padma. Thank you. Thank you all. Good night. Good night.
Thank you, everyone.
Night.
Yeah,
Thank
this
you
is
all.
recorded on YouTube, sir. We will share the link. This message, I mean, this information can be disseminated. Thank you all.
Thank you, everyone.